So without further ado, I think let's just quickly start the International Symposium. It's a pleasure and an honor to have such an august lineup of speakers and moderators and our honorable chief guest and guest of honor. So on behalf of Sultan Qaboos University, American Society for Microbiology, Hospital Infection Society India, and Dash to Protect Antibiotics, I welcome everyone to the International Symposium on Antimicrobial Stewardship and One Health. Ladies and gentlemen, it's a great pleasure for me to introduce our faculty, Department of Microbiology and Immunology, College of Medicine and Health Sciences, Sultan Qaboos University, and our amazing principal investigators of Dash to Protect Antibiotics. Some more principal investigators of Dash to Protect Antibiotics who've been working with us for the last, I think, 5 years. And I was very happy that Prof. Rashid talked about our publications. And indeed, it's been a lovely journey and a great learning experience with all our experts and our patron, Professor David Livermore, and with all the department faculty and the principal investigators. I welcome our chief guest, Professor Rashid Al-Abri, and a guest of honor, Dr. Sanjeev K. Singh. Our eminent lineup of distinguished speakers, Professor David Livermore, Professor Jean-Francois Timsit, Professor Thyri Nas, Professor Anne-Garad Davies, and Dr. Badrul Hassan. And to support them, we have this amazing uh, galaxy of esteemed moderators, Professor Raman Sardana, Professor Rajiv Soman, Professor V. Balaji, Dr. Saif Al-Abri, and Dr. Yasir M. Sanad, who will be moderating these very, very important talks. And helping us in conducting this, we have some of our valuable members of Team Dash, Professor Rajni Ekadashi, Dr. Maria Khan, Dr. Pragya, Dr. Shoaib, Dr. Ashima Singh, and Dr. Bashar. Ladies and gentlemen, before we get into the symposium, I'd just like to walk you through the carbapenem resistance in bloodstream infection in Middle East and North Africa. And you can see the greatest burden of carbapenem resistance in Klebsiella is taken up by Pakistan and Egypt, while in case of crab, it is the Kingdom of Saudi Arabia and Iran and Tunisia. Oman falls in the middle, it's more conservative, so 21 to 30% in CRKP, and double of that is seen in crab, which is 40 to 60%. The same results are mirrored in our Sultan Qaboos University pathogens. So while Pseudomonas aeruginosa is the most common pathogen, the quantum of resistance, carbapenem resistance over the last 10 years have been really shouldered by Klebsiella pneumoniae and Acinetobacter baumannii. And you can see that it's to the tune of 50 to 40%. And there's a crying need for newer antimicrobials. And fortunately, we do have several new drugs in town. In Oman, we currently have ceftazidime avibactam, and ceftolozane tazobactam has been recently introduced. While in India, Professor Rajiv Soman has informed us that they have a far bigger spectrum of drugs, so ceftazidime avibactam, cefepime zidibactam on compassionate, but they do have cefepime enmetazobactam and plazomicin as well. We'll have Professor David Livermore and Professor Timsit expound on these very important drugs. But there's another issue which needs to be addressed, and that is the issue of costs and access and equity apart from the spectrum. And just to bring you a little idea that the older drugs, which we know are not as effective, in US dollars, they cost about 1792, while the newer ones are sevenfold higher at 14,174 US dollars. So that means that even if they are available in a particular country, how many of the poor will be able to access it is naturally understandable. And that means large swathes of the population will still have to make do with the older antimicrobials for quite some time. And in Sultan Qaboos, we've been doing synergy tests for this very reason, because there is a lack of access of many of these newer antimicrobials. So we were earlier doing it with the checkerboard and time kill, and now we're trying to see if the e-test cross method could work, because that will tailor the treatment to the individual patients. And to our great perturbation, we found that synergy has declined to 50% in case of meropenem fosfomycin, OXA 232, and amikafosfomycin has again declined to 50%. In case of NDM5, the decline has been even steeper from 100 to 17, and amikacin fosfomycin has become a 0. Now, this is a significant problem for us because these were the two good combinations which were being used, and we wondered what was the genomic reason for this. So we explored the epidemiology. We found that OXA232 has declined from 82% to 62% with concomitant increase of NDM15. KPC2 got introduced 3-4 years back. And also the MLST experienced the sea change from ST231, 395, 147. We now have the hypervirulent 2096, which started from Saudi Arabia and has reached us ST11 and 147. So when we analyze the AMR virulence genes, what was increasingly what concerned us even more was the almost global presence of ARM-A, which is a 16S rRNA methyl transferase, which grants them pan aminoglycoside resistance. Fosfomycin 4 years back was 100% sensitive, and now we have FOSA gene along with the efflux genes, which contribute mayhem in terms of carbapenem resistance. And you can see that we have 2096, which is OXA232, 147, NDM1, and ST11, which carries KPC and NDM1. And you can see that these are global, while all the others, there's a distinction. And they're armed to the teeth. So not only are they carrying extreme drug resistance, they're also carrying many virulence factors. And that means that this is a foe we need to be very, very careful with. We tested these newer antimicrobials, and as expected, as you can see from the heat map, we found a 50% sensitivity to fosfomycin. And what was the biggest surprise? Because of ARM-A, we've lost plazomycin before it got introduced in Oman and maybe in the Middle East. And the same holds true for all the others. We really don't have them. But as you can see, it's not 100% susceptibility where one would expect some very good susceptibilities at this point. And it tells us that the bugs are international travelers. They need no, they recognize no borders, and we may not have the drugs, but they can travel and create havoc in all our areas. Just to give you a quick look at what the Dash to Protect Antibiotics group is doing, we have 62 centers in 13 countries. We are all tertiary care, which is a problem, except in Oman, where the Ministry of Health partners with us. So we had data from primary health centers as well. But the good news is that despite the fact that this data is skewed towards resistance, nitrofurantoin and fosfomycin worked very well, which tells us that in the community, the rates are going to be even better, and they should definitely be the drugs of choice, and we should spare all sorts of other drugs, including carbapenem, for management of simple cystitis. But when we analyze the susceptibility across high income and low and medium income countries, you can see nitrofurantoin resistance is creeping in with 84%. And here is Ukraine, and you can see how the war is impacting susceptibility even to these drugs, with 85% for nitrofurantoin and 82% to fosfomycin. And another thing I'd like to draw your attention to is the fact that Middle East does not test fosfomycin for cystitis, which is actually good because I just showed you how much resistance there already is. So we don't, routinely, we do not test it, and it's not available for simple cystitis. So in our lab, we felt that with nitrofurantoin resistance creeping in, that we need to look for alternatives for nitrofurantoin, and as well, which will of course become carbapenem sparing alternatives as well. And we found fosfomycin, mesalenam, nitroxylan, and temocillin with 100% for fosfomycin, mesalenam, nitroxylan, and temocillin was 87.5%. So these are the two drugs, mesalenam and nitroxylan, which need to be introduced, say, in the Indian subcontinent and other LMICs, and fosfomycin too should be introduced. But again, there can be a debate on whether we should introduce it, given the resistance we're seeing to fosfomycin. So that's something we would love to do with our DASH group as well. We test it and we make recommendations regarding the utility of these drugs in our areas. The other important thing we'd like to do is map ESBL, AMP-C, CRE in our regions. It couldn't be done phenotypically. It's cheaper, but it takes more effort and requires more expertise. So we're looking at grants where we can use LFIAs to identify ESBLs and CREs. AMP-C LFIAs are not really available, but that's something we would love to do provided we get the grant. So we're still looking at grants at this point in time. We'll hear Professor Tyree Nas talk in great detail about this during his talk. We have Professor Angarat Davies who will talk about antimicrobial stewardship in Wales. And we're doing a little bit of stewardship in this study as well. And currently we're focusing on OBS and gynae. The first aim is to understand the prescribing pattern and then to educate them appropriately. So you can see our colleagues are filling in the questionnaire. It's not a very easy, simple questionnaire. It takes some time, more like an exam, they tell me. But thanks to all of them, Anna PIs for really going in for it. And this questionnaire is in the shape of vignettes, real life vignettes, which they can relate to from their real life OPD situations. And then we ask them which antimicrobial is it that they would like to use. It doesn't stop there. We ask them the first choice, second choice, and third, and so on. And that promotes reflective thinking in terms of which antibiotic we should use. We go back and analyze it, and we now come back for the educational session, which is now targeted to that particular group, so that it's tailored and it makes more impact. And as you can see, it's a great experience which both the PIs and our audience experience, because they realize that this is some kind of education which is needed with the rampant antimicrobial resistance in place. All this was possible because of our patron, Professor David Livermore, who held our hand during the first paper, and Professor Rashid Al-Abri, our local patron, and of course, all our wonderful experts who have been with us through thick and thin, and of course, the PIs and the clinical colleagues. So ladies and gentlemen, now please join me in welcoming Professor Rashid Al-Abri, who's our chief guest. We're totally, totally delighted to have you. And to welcome him, we have our dynamic Dr. Zaima Al-Jabri, who will first introduce herself and then do the honors.
Thank you, Dr. Meher. Thank you so much. I am Dr. Zaima Al-Jabri. I am the Associate Professor in the Microbiology and Immunology Department, Head of Department also in the College of Medicine and Health Sciences, Sultan Qaboos University, Oman. And it's my distinct honor to be here with you all today. I'm going to start by welcoming Dr. Prof. Rashid Al-Abri. He is our esteemed chief guest. He's a distinguished leader and pioneer in medicine and health sciences in Oman, currently serving as the Dean of College of Medicine and Health Sciences at Sultan Qaboos University. He is a professor and senior consultant in ear, nose, and throat surgery department or unit in the surgery department, with a legacy that has shaped our institution and impacted healthcare in Oman. He is a graduate of the first batch of College of Medicine and Health Sciences at Sultan Qaboos University. He was awarded his MD in 1993, marking the beginning of an exceptional career. He pursued a postgraduate training in the United Kingdom, where he achieved his FRCS in 1999. From 2004 to 2018, he was the head of ENT unit within the Department of Surgery, establishing it as a leading center of excellence. And as a director of development and quality at Sultan Qaboos University Hospital from 2006 to 2013, he introduced transformative quality initiatives and programs, elevating the hospital standards to international acclaim, yielding significant advancements. He spearheaded an establishment of a comprehensive risk management program and improved health and safety guidelines, quality management protocols, and internal auditing systems at Sultan Qaboos University Hospital. He further contributed to Oman's medical education as the program director for the ENT residency program at the Oman Medical Specialty Board from 2007 to 2016. From 2016 to 2022, he served as the head of the Medical Education and Informatics Department, where he played a key role in advancing medical education methodologies and integrating modern learning technologies. In his role as the head of Medical Education and Informatics, Professor Rashid Al-Abri elevated the unit to an academic department, expanded skills lab activities, and introduced simulators for medical student training. He played a key role in establishing online learning, aligning within the college new vision. These accomplishments garnered their recognition from the World Health Organization, which appointed him as a chair for the WHO Collaborating Center for Quality and Patient Safety Training in Oman, the first such center in Eastern Mediterranean region from 2018 to 2022. Prof. Rashid Al-Abri, an esteemed academic and medical professional, has published extensively with an H-index of 25 and over 14,000 citations. That demonstrates his influential contribution. Prof. Rashid Al-Abri also serves as a reviewer and editor for regional and international peer-reviewed journals. And these journals has also actively involved in academic mentorship, overseeing undergraduates, postgraduate research projects. Today, as we celebrate our continued journey in medical education and healthcare, we are privileged to be joined by a visionary whose dedication and accomplishments inspires us all. Please join us in warmly welcoming our chief guest, Prof. Rashid Al-Abri. Welcome to our symposium today.
Thank you, Dr. Zaima, for this really nice introduction. And really, maybe I didn't deserve it, but thank you for that nice introduction. I would like to thank you all and Dr. Meher Razvi for this important event organization with your team. And dear colleagues, I would like to welcome you to this important meeting on the International Symposium on Antimicrobial Stewardship and One Health. And I believe all of us heading for patient safety by doing this sort of the collaboration. I'm really happy to support at Sultan Qaboos University, support this sort of collaboration in research and also in educational events, where we would like to have you all, hopefully one day, as I said earlier, in the Sultanate of Oman, in a meeting, a physical meeting, face to face. And I believe Dr. Zaima and Dr. Meher Razvi will organize that in the nearest future. And I'll support that for the future, inshallah, because that will bring all more academics also to be meeting you from different specialty in Oman, different hospitals from Oman. Today, I'm happy to see more than 200 who's attended this international symposium online. Actually, 222, including us, which is a good number, 222. And that's really also creating a good chance for everybody. I like number 2. And but everybody of you, I believe, number 1 in this field. And I would like to welcome the speakers and some moderator for the symposium and the organizing committee who put hard, really time to organize it. And I've seen it myself from different email I receive over the last few months. And I'm sure it'll be a success. And the success is appearing now from the attendance and from yourself, either the speakers from international speakers or local organizer. So I would like to thank you all and welcome to this symposium. Please, we are encouraging this sort of collaboration and come with good ideas out of this meeting. I've seen a lot of publication being there, and I'm sure things will come much better in the future. So I wish you all the success, and thank you again for inviting me to be with you. Thanks again.
Thank you. Thank you so much, Prof. Abri, for that amazing, amazing words of encouragement which you gave us, and your insight and your appreciation of the hard work we've been doing and the efforts which the whole team has been doing, including your recognition of our work as Dash to Protect Antibiotics, and your great welcome and future hope that we can hold a in-person meeting where we can meet all our esteemed panelists in person and the audience. The audience is so very important for us. So thank you, sir. And I would, it's now my distinct honor to welcome Dr. Sanjeev Singh, one of the first experts who I reached out to, because it's amazing how accessible he is. He's amazingly busy. He is a multifaceted personality, and yet he is so accessible. And I thank you so much for that. I would like to welcome our dashing principal investigator, Dr. Ekadashi Rajni, who has also helped us get the HMSC certificate, to please do the honors. Dr. Rajni, please introduce yourself first.
Yes, ma'am. Good evening, everyone. I'm Dr. Rajni, Professor Microbiology at Mahatma Gandhi Medical College, Jaipur, India. And it's my privilege and an honor to introduce our distinguished guest of honor, Dr. Sanjeev Singh, Medical Director at Amrita Institute of Medical Sciences, Kochi, India. This is a name synonymous with excellence in healthcare leadership, patient safety, and infectious disease management. A postgraduate in pediatrics, Sir has a master's in hospital management and a PhD in infectious diseases as well. He is a global learner and holds fellowships in patient safety from the University of Virginia and Health Technology Assessment, University of Adelaide, Australia. Sir's contributions extend far beyond the institutional domain. Dr. Singh has been a regional coordinator for the WHO's disease eradication program and technical advisor to the Government of Kerala for antibiotic stewardship, infection prevention and control, and several other quality improvement initiatives. He also serves on several national committees, including the Drug Safety Council, the FICCI Healthcare Committee, the Association of Healthcare Providers, and NABH Technical Board, to name a few, playing an absolutely key role in shaping healthcare policy and quality standards. Sir is a prolific writer and an academician with over 100 publications and 14 funded research projects. We are truly privileged today to have with us a visionary and an advocate for safe and sustainable healthcare. So, ladies and gentlemen, please join me in extending a warm welcome to our esteemed guest of honor, Dr. Sanjeev Singh. Sir.
Thank you so much. It is so formal that Dr. Rajni, I don't know whether you know, I belong to Jaipur, and I don't know whether it was planned very well by Dr. Meher. So thank you so much. I really like to congratulate Dr. Meher and her effort, and I have been seeing phenomenal work which she is able to accomplish, getting people together. It is so difficult because everybody is very busy doing fantastic work, but getting people to collaborate and team. I think she has the magic and a very magical team. So fantastic work, Dr. Meher, and congratulations. Professor Rashid very rightly said that there has been a lot of extraordinary and special work which has been done, and congratulations for the recent publication and all the speakers and moderators, and they have been sort of my gurus, and it is so good to be in this platform. You shared your presentation, which was, again, every presentation in AMR shakes you, that the synergies which you thought it's working, it's not working. You are surpassing the molecular diagnostics gives you a very, very different perspective. The newer antibiotic, Plazocine, was again a fantastic surprise that thought got introduced and it's going to help, but it is already resistant. But getting 62 centers together for your dash to protect antibiotic is a really great step. We know AMR is a global and a patient safety agenda. We know that there is right now a huge morbidity, mortality, and the cost of care which has been increasing. I'd just like to share a personal thing. My wife, who's a professor of anesthesia, had some spondylolisthesis, S1, S2 fracture, and disc prolapse, and she was slated for internal fixation and laminectomy. And when she went into the theater for a subclavian, unfortunately, the sonography guided insertion was not done, and it was blind, and they perforated the subclavian artery. And soon they realized that the blood pressure dropped to 60/40 prone. And they realized that now they need to do an echo, and they realized that there is a cardiac tamponade. From a sterile zone, she was shifted to another sterile zone, which is cath lab, and pericardiocentesis was done. And within 48 hours, there was Acinetobacter growing. So within one sterile zone, moving to another sterile zone, having all sterile practices, the bug is beating you at every corner. And you grew, and then there was which is completely, and we keep saying that it is all preventable. This was completely preventable. 6.8 lakhs of bill, 2 days of stay, spinal surgery completely averted, not done. And then you land up with something which you never want to do it. And this is time and again we see with every patient. So I'm sure this particular session and many session which Dr. Meher and Sultan Qaboos organizes will be a great learning opportunity. I just wish that all this training also leads to change in the behavior, change in the attitude, change in the practices. And phenomenal work, Dr. Meher. Please keep doing the great work which you do. And let's all sort of every time come together and make the change which is so very important. So thank you so much, and hope this is very, very productive to all of you.
Thank you so much, sir. Thank you so much, sir. You're always an inspiration. I just wish your personal experience had not happened ever. But sometimes I think God does it for a purpose, because you're leading AMR from the front. And that personal experience is what maybe, like galvanizing you, because it's when the pain hits personally, that's when things start happening at a magical level, which you're so fond of. But I wish it really hadn't happened. And lots of regards to Madam. And you're an inspiration for all of us. And thanks for sharing your insights and for leading the way in infection prevention control, in patient safety, in antimicrobial resistance. And Godspeed to you, sir, and to Madam. Thank you so much. Ladies and gentlemen, we are now about to commence the International Symposium after having had such lovely words of encouragement from our chief guest and guest of honor. And totally delighted to have Professor David Livermore with us, who will be talking on clinical use of newer antibiotics against extremely drug-resistant gram-negatives. Always an honor to welcome our Professor Dr. Raman Sardana, who is a co-organizer of this event. His presence makes things so much more comfortable and easier for us, because he is a big brother and an expert in so many things, including event management. So thank you so much, sir. And to welcome you, I invite another dynamic PI, Dr. Maria Khan from Peshawar, Pakistan. Dr. Maria, please.
Thank you, Dr. Meher. Good evening, everyone, and Assalamu alaikum. So as we continue our exploration of the symposium, it's crucial to hear from those on the cutting edge. So our very first moderator for this session is Dr. Raman Sardana, who is widely recognized as a leading voice in antimicrobial resistance. Dr. Raman is actually a professor adjunct in clinical microbiology and infection control and Raprashta Apollo Hospital, New Delhi. And he's a director board of trustees, the IFIC UK, honorary secretary Hospital Infection Society India at New Delhi. And he's also a member committee on hospital infection control and biomedical waste, Bureau of Indian Standards, and a member of Government of India experts on National Patient Safety Mobilization Network, member technical working group blood-borne viruses and dialysis NCDC, Government of India. He has been awarded the Prashasti Patra by Government of India for Pulse Polio program in 1995. He also conceptualized and instrumentalized the Guinness World Record on hand sanitizing relay at Indraprastha Apollo Hospital, Delhi, and the first recorded established by the India. He is a recipient of Scroll of Honor from Delhi Medical Association and other non-governmental agencies. And he has co-authored National Treatment Guidelines on Infectious Diseases and National Patient Safety Network Implementation Framework for the Government of India and National Action Plan Combating Viral Hepatitis in India in 2019. And he's also a National Infection Control Guideline he has also established this in 2014. He's been publications for 67 articles, in which he also co-authored and authored 14 prestigious books for chapters, 5 prestigious prestigious publication with national academic societies, almost 112 abstracts in regional, national, and international conferences. And he's also on a teaching faculty in microbiology and clinical and nursing specialties for past 32 years, guided and co-guided 48 postgraduate theses in different specialties and directed more than 104 postgraduate research projects. So actually, this symposium, the challenges we are facing, as highlighted by Dr. Meher, we require innovative thinkers. And we are incredibly fortunate to have Dr. Raman Sardana with us here today. Dr. Raman, please carry on.
Thanks, Dr. Maria Khan, for that very, very kind introduction. I always tell Mayor that, putting too many things on the host is something which is not desirable, but she retains that slide and keeps on updating it. So it's a won't stand between the stalwart and you people. We know that antimicrobial resistance is ancient, and who else in this today's world than to talk about the antimicrobial resistance, whose first one of the first articles on natural resistance came in JAC, which I read very lucidly and keep on reminding the people about that article. It forms a part of my presentations almost every time. Was in JAC 48 supplement 1, which was on talked about natural resistance, and then afterwards it's been a history to talk about, and his contributions in spreading good word about antimicrobial resistance and how to contain it at least. So let's hear the senior voice on this, Professor David Livermore. Can I go back to the previous slide, please? Yeah, he began his career in 1980 as research assistant at the then London.
Just a moment. I need to just correct the spelling. I'm so sorry. Just a minute. Just a minute. This cannot be done, Just.
Don't worry about that.
Oh, it's all right. He is. So don't
I
worry
know.
about it.
No, this is crazy.
Don't worry.
This
Simple
can't be
typo. I've made
done.
hundreds of them. Don't worry
No.
about.
Yeah.
No. Yes.
And so like taking over from Mayor, yes. So he wrote his PhD on the side when working at London Hospital Medical College, and by 1994 he became a senior lecturer in medical microbiology and moved to Public Health Laboratory. Now it is called as Health Security Agency, or HSA, swiftly becoming the director of antimicrobial resistance monitoring and reference laboratory. So he remained until 2011 when he moved to the University of East Anglia as professor of medical microbiology. I took some time to pronounce it. I'm still not very sure whether it's the correct pronunciation. So now he's kind of taken a back seat, but he retains an honorary professorship with UEA and consults widely for the medical industry on antibiotic development and rapid diagnostics. So can I have the next slide, please? And I have told you about the antimicrobial resistance, the natural antimicrobial resistance. He has authored over 500 papers, wow, and appears on Clarivate's most cited list, as edited for multiple microbiological journals, and served on UK government's advisory committees on AMR and healthcare infections. So he has been a consistent public critic of lockdown policies during the COVID-19 pandemic and of the overuse of novel type of vaccine in low-risk populations. So besides his academic work, he is an ace photographer, and especially amongst the wild orchids, and has walked the whole UK perimeter. So that's to him, and the stalwart now with you, a legend, in fact. So Professor David Livermore, please deliver on clinical use of newer antimicrobials as we face the major challenges of today's world on AMR, with novel targets, climate changes, drugs, introduction of various means of research on common drugs that have suboptimal antimicrobial properties and which add on to this burden. So Professor Livermore, please.
Okay, well, many thanks indeed for the kind and fulsome introduction. It's a pleasure to be here today. Perhaps somebody can tell me whether I'm supposed to share the slides from here, or if
Yes.
you've got, I should
So-
share them from here. Jolly good.
Yeah.
1/2 moment while I do so. In that case,
We get to see you in the meantime, which is good.
well, I'm not sure about that. I look older every time I see my own photograph.
Old is gold, sir.
Somehow we're halfway through the slide deck there. Let's go back to the beginning. Can you see the first slide now?
Yes, sir.
Jolly good. Okay. Well, as I say, a great pleasure to be here today to talk about new antibiotics and their use. I'm told that nowadays I should always start with a disclosure slide. As has been said, I continue to do some consulting for the medical and device industry, although I'm substantially retired now. Bit of consulting, occasional lectures. I have a few shares in different companies, and despite this glorious history, I'm not entirely popular with the UK government for having spoken out against the use of COVID vaccines, particularly in children during the recent pandemic, though I see that even America has now stopped advocating COVID vaccines for children. But let's steer clear of COVID for the afternoon and talk about antibiotics. We went through a long period in the late 1990s and the first decade of this century when there were very few new antibiotics launched that had any activity against gram-negatives. Yes, new anti-MRSA agents came, new pneumococcal agents, but nothing very much against gram-negatives. That's now changing, and over the past 10 years, we've seen the launch, and it obviously varies somewhat between countries, but internationally, we've seen the launch now of 6 new beta-lactamase inhibitor combinations, a new tetracycline, a ribociclib, a catechol cephalosporin, cefidrochol, and in a few countries, a new aminoglycoside, plazomicin. More are coming: cefepime zidibactam, cefepime nacobactam, cefepime taniborbactam. We're soon going to have lots of different combinations with cefepime to create great confusion, I fear, among the unwary. But what I'm going to try to argue through this presentation, that these are very much horses for courses. And you can see it on the slide. Some are active against Enterobacterales with one resistance type, but not Pseudomonas with another resistance type. And really, one needs quite a close knowledge of horses for courses. So let's try to break this list down somewhat. There's 2 combinations there that use penicillinic acid sulfones, so N-metazobactam and ceftolozane with tazobactam. Now, everybody's familiar with tazobactam. It's been combined with piperacillin for at least 25, if not 30 years now. N-metazobactam's less familiar, but it's a modification of tazobactam with an additional methyl group added. It's pharmacodynamically rather better. It's got a longer half-life, and it's got a rather stronger inhibitory activity to tazobactam, though a fundamentally similar one. It's been put with cefepime. Now, the point there is that cefepime is an easier compound to protect than, say, piperacillin. Cepepime's more stable, particularly to AMP-C beta-lactamases. So you're looking here, cefepime and tazobactam, we'll see in a moment, a very broad spectrum of activity. Also, whereas piperacillin tazobactam often isn't active against ESBL producers. That's not owing to a failure to inhibit the ESBL. It's because they've often also got OXA1, which is a penicillinase, which isn't inhibited by tazobactam. Well, cefepim's stable to it, so it doesn't matter. And then cefepime and tazobactam may, and I stress the word may, also have some activity against OXA48 producers, but there's scant clinical evidence as yet. Pseudomonas I'll come back to. But there you see the data. Now, these are Europe. These are Enterobacterales, resistant to third-generation cephalosporins. Very few of them have got carbapenemases, but almost all of them have got an ESBL or an AMP-C. Orange bars cefepime alone, lighter orange is piptazole, but blue is cefepime and tazobactam, showing almost as good as ceftazidime avibactam. So this is a new option coming against problem Enterobacterales. Questionable if there's a carbapenemase, but for the commoner garden ESBL AMP-C producer, a lot more potent than piptazole. Ceftolozane, not as easy to protect as cefepime. It's not stable to AMP-C, and it's been put with tazobactam, that older, less potent inhibitor. But where it's interesting is Pseudomonas. Now, these are Pseudomonas sent to the UK National Reference Laboratory, percent susceptibility. Now, if you look at the older beta-lactams, piptazole or ceftazidime, well, if there's a high-level AMP-C enzyme, 80% are resistant. If there's upregulated efflux, well, depends how strongly it's upregulated, but anywhere up to, 73% resistance. Ceftolozane tazo keeping activity against these groups. Once there's an exotic beta-lactamase like an MBL or even an ESBL, and they're mostly VEB types in Pseudomonas, then it falls over. But these are rarer than upregulated efflux and AMP-C. And that follows through clinically. Here's a nice little study from Barcelona in Spain, 38 cases, very multi-resistant Pseudomonas, susceptible though to ceftolozane tazo, MICs between 1 and 4 mg per litre, treated with ceftolozane tazo, usually at high dose. Frankly, for bugs like this, it should always be high dose. And 86%, 87% clinical response. That's pretty good for such multi-resistant, difficult Pseudomonas in patients where, a third of them were bacteremic. But in several cases, whoops, we've gone over, 4 cases, there was emergence of resistance. And that was usually a sequence change in the AMP-C beta-lactamase, making it a better ceftolozanase. So what I'd say about these inhibitor combinations, cefepime and tazobactam, good against ESBL and AMP-C Enterobacterales. It's going to be more expensive for the time being, but perhaps we should see it as the future workhorse replacing piptazole. Ceftolozane tazo, anti-Pseudomonas drug, good one. I don't see much role outside Pseudomonas. Let's come to the non-sulfone inhibitors now. They're mostly diazobicyclooctanes. So we've got ceftazidime with avibactam, now also aztreonam with avibactam, imipenem with relebactam. Those are all related inhibitors. They're diazobicyclooctanes. Then meropenem with a completely different inhibitor, a boronate called vaborbactam. Now, here's ceftazidime avibactam, which has been about for the longest of these. This is in the United States, looking at carbapenemase positive Enterobacterales. Clinical outcomes. And because it's the United States, then it's almost all KPC carbaphenemases. Avibactam inhibits KPC carbaphenemases really very well. And if you look at deaths in hospital, this is experience rather than randomized trial, but lower death rate than with the previously used colistin combination and more discharged home. And this is the sort of result that's been replicated elsewhere, that this combination of ceftazidime with avibactam comes out better against KPC enterobacterales than the previously used colistin combinations. Against OXA48 producers, well, ceftazidime is actually stable to OXA48, but many of the isolates with OXA48 have also got the ESBLs. So what's happening here is the avibactam's inhibiting the ESBL. The OXA48 can't attack the ceftazidime, so the ceftazidime can then get to work against the bacteria. These are OXA48 producers in Spain. Very difficult patients. Look at those Apache scores, an average of 24. 54% of these patients were septic, extremely multi-resistant. They receive ceftazidime avibactam. 49 out of 57 survive, including 80% survival where the ceftazidime avibactam was given as monotherapy. So, ceftazidime avibactam, no possible doubt, a good option against producers of KPC and OXA48 type carbaphenemases. But avibactam won't inhibit a metallocarbaphenemase, and a metallocarbaphenemase will attack ceftazidime. And that's the rationale between developing now aztreonam with avibactam. Avibactam doesn't inhibit metallocarbaphenemases, I've just said, but aztreonam is stable to them. So the logic is avibactam will inhibit every other beta-lactamase, avibactam stable to the MBL, so the combination of aztreonam avibactam is very active against virtually all enterobacterales with carbaphenemases. Doesn't matter if they're KPC types or OXA48 types or whether they're even metallotypes. Clinical results are starting to dribble through, and Pfizer have published 2 relevant clinical trials, Revisit and Assemble. Now, Revisit's peculiar. It's a mixture of pneumonias and intra-abdominal. In general, aztreonam avibactam against multi-resistant pathogens. In general, aztreonam avibactam with metronidazole performed as well as meropenem with or without colistin. However, once you get down to the MBL producers, the critical ones, this combination, only 2 out of 7 good outcomes and 2 out of 3 for the meropenem with or without colistin. So tiny numbers are not impressive. This was supposed to be a bigger trial, but against MBL producers specifically, but recruitment was messed up by the pandemic. They only recruited 12 patients. Aztreonam avibactam cures in 5 of 12 MBL producers, as against 0 of 3 in best available therapy. So one has to say some positive pointers, but tiny numbers of patients. We need a lot more experience here. That's a concern. Here's another concern going back to ceftazidime avibactam. These are consecutive patients with carbapenem-resistant enterobacterales. The huge majority, 27 out of 37, with KPC carbaphenemases at University of Pittsburgh. Diverse infections, good overall cure rate, but 3 out of the 27 cases, there's emergence of resistance through mutation to the sequence of the KPC carbapenemase. And that's a mode of emerging resistance that's turned up worldwide. Not yet common, but scattered. It is a concern. Turn now to meropenem with Weber-Bactam. This Weber-Bactam will only inhibit KPC carbapenemases. If your Klebsiella or whatever's got a KPC carbapenemase, meropenem Weber-Bactam's an option. If it's got OXA48 or a metallo, it isn't. They did a nice little clinical trial against KPC enterobacterales, against best available therapy, which was usually a colistin combination. And really, however you cut the data, it came up in favour of meropenem Weber-Bactam. Emerging resistance has been less of an issue than with ceftazidime avibactam, but the drug's been less used, and there have been odd reports through reduced permeability. Next one to talk of, in fact, the last of these inhibitor combinations, imipenem with relebactam. They did a big trial in hospital-acquired pneumonia, ventilator pneumonia, but most of those weren't terribly resistant isolates. So again, I've just put up the resistant isolates trial. These were imipenem resistant infections, most of them, or at least half of them, due to Pseudomonas with impermeability type resistance. Now, it sounds mad to use a beta-lactamase inhibitor combination against bugs with impermeability type resistance. However, in Pseudomonas, that impermeability type resistance also requires the chromosomal AMP-C enzyme. And if you inhibit that, then the permeability alone won't give the resistance. So they got decent results, 13 out of 16 positive results with these imipenem resistant Pseudomonas, as against 5 out of 8 with imipenem colistin, which give a lot more toxicity. Among this tiny trial, there were only 4 patients with KPC with carbapenemase producing Enterobacterales. They all had KPC Klebsiella, and only 1 out of 4 of them had a good result. Now, as with the Aztreonam avibactam and metallocarbapenemase producers, it's tiny, it may be bad luck, it ought to be active, but more experience is needed. Lastly, let me move away from beta-lactamase inhibitor combinations. I'm not going to say any more about plasmamycin, except that where a bug has got an NDM carbapenemase, as May has already said, that's often on a plasmid that also encodes a ribosomal methyltransferase, which modifies the ribosomes so that they won't bind any aminoglycoside, including plasmamycin. So that's a bit of a problem, particularly in the Middle East and India, where one has so much NDM carbapenemase, as I say, accompanied by methyltransferases. But the other two, cafidrocol and eravacycline. Cafidrocol is actually the broadest spectrum of all these new antibiotics that I've spoken of today. It's a catechol cephalosporin. What that means is it's got this group here, a benzene ring with 2 adjacent hydroxyls. That's a catechol. That binds iron. Bacteria are scavenging for iron all the time. They use catechols themselves, and they mistake this complexed with iron for their normal iron scavengers, and they actively bring it into the cell where, bingo, it binds to the penicillin binding proteins and poisons the bacteria. Shionogi, credit to them, did a big resistant pathogens trial. However, it didn't turn out as well as one might have hoped. This is survival probability, a Kaplan-Meier plot. Cafidrocol's the solid line, best available therapy is the dashed line. And as you see, the cafidrocol didn't do as well in terms of survival as the so-called best available therapy. Now that was largely down to carbapenem-resistant Acinetobacters. If you look at the other groups, the Klebsiellas and the Pseudomonas were actually against Klebsiella. Cafidrocol was doing better than best available therapy. Pseudomonas, the numbers are tiny, it's not statistically significant. The problem with Acinetobacter. So against Enterobacterales and Pseudomonas, I would not be put off by that credible trial. I would be cautious with regard to Acinetobacter. Here are the metallocarbapenemase producers, and one has to say that these look better than the results I just showed you for Aztreonam avibactam. So this is again from credible CR, clinical cure, microbiological eradication, Cafidrocol against best available therapy. And you're looking at 60s, 70% there, at least for clinical cure, less good inevitably for microbiological eradication. Again, though, in that trial, and this made part of the issue with Acinetobacter, some emergence of resistance. MICs going up from 1/4 or 1 mg per litre to 4 or 8 mg per litre. And as I say, the problems in credible trial mostly associated with poorer outcomes for Acinetobacter. And here I think is the clue, some emergence of resistance. As I've said, better results though with Enterobacterales, but even here, some emergence of resistance during Cafidrocol therapy. This isn't in the clinical trial. This is a later clinical case. There have been others reported. This was an Enterobacter cloacae, but it's seen also with Klebsiella. Remember, this drug requires the ion transporters to get into the bacteria. Bugs can switch between different types of ion uptake mechanism. This is what's happened here. A catechol receptor, SIR-A, has been inactivated during treatment, and the MIC going up from 1 mg per litre to sky high. Where to prefer Cafidrocol then? Well, I do think it's the drug of choice against MBL-producing Enterobacterales. Aztreonam avibactam may displace it, but we need more data, and certainly against MBL-producing Pseudomonas. Also Pseudomonas that have got extended spectrum beta-lactamases. Remember how resistant they were to ceftolozane tazobactam. Final drug to mention, eravacycline. We finally left the beta-lactams. We've got a tetracycline. This one's simple to summarize. It's like tigecycline, which you're all familiar with, but it's got better pharmacodynamics. Higher dosage, get a bit higher level, the MICs are a tube lower than tigecycline, and there's less gastrointestinal disturbance. Unfortunately, the data are limited. Successful trial in intra-abdominal infections, or rather 2 successful trials, 2 failed trials in complicated urinary tract infections, probably because it's largely got biliary excretion. This was a crazy setting in which ever to do a trial with a tetracycline. My view would be that you should consider it where you're considering tigecycline. At the very least, you're less likely to make your patient nauseous. So let me finish by repeating what I said at the start. We are looking at new drugs against gram-negatives. Some of them are really very promising, but none of them is a universal panacea for problem gram-negatives. It's horses for courses. Ceftolozane tazobactam, and based on what data we have at present, imipenem relebactam, I would see as drugs against problem Pseudomonas. Maybe that imipenem relebactam is an option against KPC Enterobacterales as well, but we need more data. Cefepime and metazobactam, future workhorse replacement for piptasil. Maybe a partial answer against OXA48, but more data needed. Ceftazidime avibactam, good provenance now against KPC and OXA48 Enterobacterales, but some risk of emerging resistance with KPC. Aztreonam avibactam, broader spectrum than ceftazidime avibactam against carbapenemase producing Enterobacterales. In vitro, it includes MBL producers, but the early clinical data against MBL producers are underwhelming. More data needed. Meropenem-vapobactam, good option against KPC Enterobacterales, but no interest for anything else. Cefidrochol, good option against MBL producing Enterobacterales, regardless of beta-lactamase type and Pseudomonas. Be careful with Acinetobacter. Ivericycline, think about it while you're presently thinking about tigecycline. Overall, I do think that with these new options, there's less role for colistin. It doesn't have outstandingly good outcomes. It's often been the best available therapy base in the trials I've talked of, and it doesn't have a good toxicity profile. Sorry if I've gone a moment over. I hope you found it interesting. Thank you.
So thanks a lot, Professor David Livermore, and as expected and as always, looking forward to it's a talk par excellence. You brought out everything which is there and the significance so subtle, in a subtle way that there is no antimicrobial which is going to be a perfect antimicrobial and sustaining itself throughout. You also brought about the reality that there would either be a resistance mechanism or the way microbes would develop how to circumvent the new anti-microbials whenever they are introduced, or there would be a way to replace till that these resistance mechanisms develop and establish themselves. There would be way of survival. So they might take a backseat for some time and let the inherently resistant bacteria come into fore. And then again, this is how the microbial world behaves, in fact. So, which brings us to something like mass specking hypothesis, if people have gone through it. If not, then I think it's time that people should go through it, which talks about that, everything is everywhere. But the environment selects or the nature selects. So that is what, if we create an environment, then definitely selection pressures would lead to the way microbes, the newer antimicrobials whenever they're introduced. Excess costs and, there would be a factor, especially in limit countries and even in the Western world. So we look forward to anything which is from the audience. Any questions from the audience which have been put across?
Everybody has appreciated the talk. Everybody is absolutely floored with the brilliant treatment given to this very important and difficult understanding of the newer antimicrobials. I don't see any questions. Dr. Maria, do you see any questions which should be addressed?
Dr. Meher, as you said, everybody is actually appreciating the talk by Dr. David Livermore. I can't see any questions right now. Maybe we can take them if we have them in the moment. We will take them.
Yeah, I think that'd be wonderful. Thank you, Professor David Livermore, as expected. And I'm so happy we have a large audience who can understand and digest and appreciate the fantastic feast you laid out in front of us. Just one question, sir. Do you think Astronam avibactam will be cheaper than cefiderocol?
I have no insight into relative
Costing.
pricing policies.
Right.
I think that will depend upon country and market.
Yeah, I suppose so. But I just hope that it'll be cheaper than, because cefiderocol is terribly expensive, and I hope it's become we do have something. So, thank you so much, sir, for your valuable time and for sharing your valuable wisdom with all of us. It's been an amazing experience. Thank you so much.
My pleasure.
The way he explains is amazing, amazing as ever.
Yes,
Thank you,
absolutely.
Professor David Livermore. Thank you. It's always a treat.
Ladies and
Thank
gentlemen,
you.
we move forward to the next amazing speaker, and I had another message which if the audience goes to the message, Professor Jean-Francois Rimsit will be using Mentimeter for an interactive session, which is so very important, for us to understand and appreciate the nitty and gritty of this very important topic. So if you could all, if you're logged in through your laptop or through your phone, just download Mentimeter from Google, and then there is I don't know where that, here it is. So I've shared the code with you. So this is a message from Professor Jean-Francois Rimsit. Join your phone or laptop to menti.com, enter the code 613025543. It's there also in the chat because we need to move forward. So please log in, and that'll give you a wonderful experience so that we learn and we travel and we learn together. So for this much awaited talk, we have another distinguished moderator with us, Professor Rajiv Soman. And thank you so much, sir, for your valuable time and your expertise, which you always give when you come to our platform. To welcome him, we have another, I mean, it's amazing how many wonderful PIs we have in Dash to Protect. This is another young PI, Dr. Pragya Paramita Jena. Will you please introduce yourself and then welcome Professor Rajiv Pragya?
Thank you so much, ma'am. Good evening, everyone. And I'm Dr. Pragya Jena. I am working as an associate professor in the Department of Microbiology, Institute of Medical Science and Som Hospital, Bhubaneswar Shiksha Anusandhan University, Odisha in India. And it is my honor to be here and to be part of this wonderful and magnificent drive that is Dash to Protect Antibiotics. I take my immense pride in introducing Dr. Rajiv Soman, a distinguished figure in the field of infectious disease, whose dedication and depth of expertise have profoundly shaped the clinical practice and education in India and beyond. As a senior infectious disease physician at Jupiter Hospitals and Dinanath Mangeshkar Hospital, Pune, and a courtesy visiting consultant at BTech into the National Hospital, Mumbai. And Dr. Soman has exemplified excellence in patient care, research, and mentorship. A fellow of the Infectious Disease Society of America and co-chairman of the Fungal Infections Study Forum, Dr. Soman is instrumental in advancing understanding and management of complex infections. His leadership as an executive and founder member of Clinical Infectious Disease Society and editor-in-chief of the Journal of Infectious Disease Society reflects his enduring commitment. His contribution extends to authorship of several case books, including those on infectious disease, invasive fungal infections, HIV medicines, COVID-19, which continues to guide the practitioners. And through his clinical wisdom, scholarly vision, and unwavering pursuit of better health outcomes, Dr. Soman continues to inspire a generation of physicians to approach medicines not merely as a science, but as a vocation of service and integrity. We welcome you, sir. Hello.
Thank you, Dr. Pragya. And we're honored indeed to have a distinguished speaker, Professor Jean-Francois Rimsit, and to welcome him and to introduce him, we're very honored to have Dr. Rajiv Soman.
Good evening, friends, and it's indeed a great pleasure to be on this call. And please join me, all of you, in welcoming Dr. Rimsit, who is a very renowned ID physician and infectious disease authority from France. And so he's the director of the Medical Infectious ICU I don't know how to pronounce it, in Paris, France, and he also manages a research team at INSERM, which is a very famous name too. Professor Timsit has a PhD in epidemiology and in public health. His clinical research interests include sepsis, nosocomial infections, adverse events in the ICU, evaluation of the risk of death associated with bacterial resistance. He is the research chairman of the critical care group in the European Society of Infectious Diseases, ESCMID, and is the president of the Outcome Research Network. He has published more than 650 peer-reviewed articles in the last 40 years in international and European journals. To me, one of his biggest contributions is the Empiricus trial, and Dr. Timsit has also addressed the Clinical Infectious Disease Society in India virtually, and I still remember his very, very excellent talk. And I think he had given an excellent talk on gram-negative resistance a couple of years ago. We really look forward to you, Dr. Timsit. And without much ado, I request you to begin your presentation. Thank you.
Thank you very much, Dr. Soman. Do you hear me? It's okay?
Yes.
Okay,
Yes, you
good.
sound great.
So I will share my screen and immediately go to Menti.com for playing with everybody. So I will try to put all these things. Yeah, okay. So we will play, and you have a QR code here, and in the next slide, in order to connect you, I will suppress everything in order to have a proper screen. So you can go to Menti.com with the code or flash the QR code in order to be with me and to see what do you think about this clinical case, that are true clinical case that occurred in my unit. So let's go. For a 55-year-old woman, she was quite obese. You see, 120 kilograms with a BMI of 43. It was an ARDS due to influenza infection with an ECMO, veno-venous ECMO that was started on February 10th. And you see 5 days after, she was suspected for a VAP, a first VAP, and she received 2 days of Cefepime. And due to the negativity of the BAL, we stopped antibiotic for 7 days, and there was another episode of suspicion of VAP, and this bronchoalveolar lavage grew with the methicillin susceptible Staph aureus and Streptococcus, and we start for 7-day coamoxiclav. She developed a multiple organ dysfunction under ECMO with a tubular necrosis, and the hemodialysis was started on March the 1st. On March the 2nd, there was a local cannula infection due to Candida and Proteus mirabilis, treated by 5 days of caspofungin and 7 days of cefotaxime. The patients improve progressively, and the ECMO was went on March 17th. And on March 19th, unfortunately, there was a second episode of VAP with a BAL that grew to Citrobacter causerii, 10 to the 6th, Proteus causerii, 10 to the 6th, and Haemophilus in E. coli, 10 to the 2nd. And it was treated for 7 days with meropenem. So we have all this thing in mind, and on March 26th, we perform a rectal and oropharyngeal screening with carriage, and unfortunately, the patients was carrying an Acinetobacter baumannii, and you see the antibiotic susceptibility test on the right part of the screen, and it was resistant to almost all the traditional antimicrobials. Here you have only resistance pattern, and we perform monoplex PCR for carbaphenemases, and it was positive with OXA23 and New Delhi metallo-beta-lactamase. So unfortunately, the same day she was a new shock happened with the degradation of blood gases. The PF ratio, the PaO2 FiO2 ratio was only 120. She received norepinephrine, high dose, and she was anuric. And the gram stain of the BAL fluid was with rare leukocytes, and the gram stain grew with show numerous gram-negative cocobacilli. So, my first question, what is for you the empirical therapy if we consider only Acinetobacter baumannii? So, I propose a few things. So, we will go to the next slide to vote. So I propose 9 grams of sulbactam, and of course you can choose more than one option. 2 grams of sulbactam. I propose colistin, 12 million unit loading dose, and then 4.5 million unit every 48 hours due to anuria and hemodialysis. I propose 4.5 million unit every 48 hours, and that's it. I propose Tyj, 200 loading dose and 100 BID, or Tyj 100 loading dose and 50 milligram BID, and nebulized colistin. So please try to vote to this question. Not so easy, but important to have your feeling on it. Of course, it is not easy at all. It was a lot of discussion with my staff, and a lot of things is not known at this time. I only know the carriage and the direct examination of the bronchoalveolar lavage fluid. So 27, I will see what are your feelings. So your feeling is to start colistin plus or not sulbactam, plus or not Tyj, plus or not nebulized colistin. So interesting. Clearly, there is some good things here. First of all, colistin is given with a very high loading dose, and you start with a high loading dose, and I think it is a good option because even in case of altered clearance, and here the renal function is really altered, you need to fill the sink, let's say, and you need to have a very important loading dose in order to be effective. Probably during the first day, I will have chosen 9 million units, that is to say 4.5 every 12 hours, probably. And sulbactam, if you have it, in France it is very difficult to have it, and we have only ampicillin sulbactam. Of course, 9 grams is good, and you should know, and you should have in mind that a very low dose is not effective. So you need to give at least 8, 9, and even 12 grams per day in some studies. So very difficult to reach this point, and the resistant, the efficacy of sulbactam is not clearly related to the susceptibility. So we don't know at this time, at this point. About nebulized colistin, it is the problem is the PF ratio, only 120. It is not so much, so the risk of complication is very high, and we don't know if we really give an extra chance to the patients doing it. So indeed, the risk for Acinetobacter baumannii pneumonia in this case is very high, since the patients were colonized with Acinetobacter in the throat, and you see that the risk for an infection after being colonized is more than 14% in all the meta-analysis of the data that exists worldwide, mainly in high-income country, unfortunately. So if you have it is available to have a new molecule, would you choose something? And I propose some option. Do you choose to add this kind of molecule? So you can again scan the QR code if you are disconnected. Let's go. So do you choose sulbactam burlobactam? Do you choose ceftazidime-avibactam aztreonam? Cefepime-zidebactam, cefiderocol, none of the above when you see these things. So please vote. It is interesting to look to your answers. So Acinetobacter baumannii, it is not susceptible. It carries OXA23 and also NDM, and you have this infection that we need to treat. And if you have these new molecules, which one do you choose? So I see that the majority will give sulbactam durlobactam. So you know, and David Livermore do not speak about it, but it is very interesting to have in mind this paper published a year ago about the efficacy of sulbactam durlobactam and VAP due to Acinetobacter baumannii. Unfortunately, it is only effective on OXA23 and not too much effective, and not at all even effective on metallobeta-lactamase carriers, Acinetobacter carriers. So unfortunately, sulbactam durlobactam will not be in this case a good option, despite its very interesting efficacy in OXA23. So in this case, probably not. You should know that ceftazidime-avibactam aztreonam or aztreonam-avibactam is not effective on Acinetobacter. So in this case, probably ceftazidime-avibactam aztreonam will not be a good idea, unless there is another gram-negative Enterobacter that carry New Delhi metallobeta-lactamase, but it was not the case in this case. Cefepime-zidebactam, I know that in some of the countries represented here, you have it, and cefepime-zidebactam is very interesting for Pseudomonas aeruginosa, but not really for Acinetobacter baumannii. So the chance for the molecule to be effective in this case is quite low. And cefiderocol, well, David Livermore spoke about it. And indeed, there was some clinical failure with cefiderocol in Acinetobacter baumannii infection, but it may work. But in this case, we don't know, and we need to have the susceptibility profile and the MIC before starting cefiderocol. So none of the above is at this time probably the good option for this question, or cefiderocol if we have chance, but it is not sure at all. So we have the antibiotic susceptibility profile, and you see here for the Acinetobacter, there was two germs in the bronchoalveolar lavage. In this case, there was a Citrobacter that was very susceptible, but also an Acinetobacter that was NDM carrier, OXA23 carriers, and OXA40 unknown carriers, of course. And you see here that the resistant profile was very, very important. The MIC for cefiderocol was resistant, 8 for MIC. And you see that for TIG, the MIC was not so good. There is no breakpoint. So we don't know at this time, but the MIC for TIG was not good. And David spoke about eravacyclines. The MIC was not so bad. And for colistines, the MIC was acceptable, with a susceptibility profile and an MIC of 1 in this case. So it is important to have in mind that if you use MPCR for Acinetobacter baumannii, the target OXA23 and OXA24 are not in the MPCR that is usually commercialized. So it is really an issue. So if you have no carbapenemase identified by MPCR, such as the one of FilmArray, BioFire, you are not sure that Acinetobacter is not a carrier for this OXA23. Of course, the NDM is recognized by the PCR, so it is very important to have in mind. So the clinical and biologist discussion is very, very important in this case, in order to understand the interpretation of this MPCR in front of this kind of patients. So I think it is a very important message to have in mind. So for me, the treatment of Acinetobacter baumannii is, of course, to test and to discuss with the microbiologist and to perform MIC. And we need to choose this kind of molecules, Ampicillobactam, Minot, IJ, Eravacycline, and perhaps Sulbactam durobactam if you have it, with for OXA423, but not really for NDM. And probably we need to prefer combo or a 3 antibiotic therapy, mixing ampicillin sulbactam with high dose and colistin, and perhaps mixing with cyclines. In this case, Eravacycline was the choice, but it is not sure. And for cefiderocol, we know that there is some warning, and we need complementary data. There is some cohort studies that are in favor of the use of it. The other point that is very important is that we need to optimize PK for these very difficult to treat antibiotic therapy infections with difficult to treat resistant gram-negative bacteria. There is a high volume of distribution, so we need to have a very high dose at the very beginning and to decrease the dose when the patient is stabilized, but not at the very beginning, even if the renal function is very poor. The source control is very important, and the reevaluation after 24 to 48 days is a key in this case. So the follow-up was quite good. The sulbactam MIC was not good at all. We start with sulbactam eravacycline colistin, and then eravacycline colistin IV, and the patient is stabilized, and the noradrenaline was stopped. And you should know that for eravacycline in obese patients, the level of clinical cure is quite good. There is at least one study that show that the clinical cure level was similar for obese patients and thin patients. So you need to have it in mind, and with 1 milligram per kilogram and per 12 hours, it is feasible to reach a sufficient level of this drug. After 7 days of treatment, the new BAL was done because of fever and persistent ARDS, and in this BAL, we see on the MPCR an Acinetobacter baumannii complex 10 to the 6 copies, a Proteus species 10 to the 4 copies, and Pseudomonas aeruginosa more than 10 to the 7 copies, and there was a presence of 2 carbapenemases, NDM and Vim. And the method was the one of the BioFire FilmArray. So it is the real life. So what is your suspected diagnosis here? I recall you MPCR 10 to the 6A baumannii, 10 to the 7 P. aeruginosa, Vim positive, and NDM positive. So first, it is an Acinetobacter failure, the treatment. Acinetobacter, I don't know. I am waiting the BAL culture. Pseudomonas aeruginosa false positive, Pseudomonas aeruginosa superinfection, Vim false positive results, Vim true positive due to Acinetobacter baumannii. Here is the voting, so please vote. So CRAB, VAP, CRAB not unseparatable, Pseudomonas aeruginosa false positive, Pseudomonas aeruginosa superinfection, Vim false positive, Vim flu positive. So please vote. It is very interesting and very important, in my opinion, because the use of this very rapid test will be probably a very important solution for us. And David Livermore mentioned that it is very difficult to know at the very beginning what will be the drugs that are effective in front of this DTR gram-negative bacteria. And I think we need to learn how to use this kind of MPCR, even if the sensitivity and specificity is not perfect at all, as for every diagnostic test. So probably important to try to answer to this question. So we will look at your answers. So you consider that it is possibly a failure to treat Acinetobacter baumannii. You also may consider that it is not interpretable because the number of copy is not the mirror, is not similar to the culture that go to Acinetobacter baumannii. Some of you consider that it is a false positive result for Pseudomonas aeruginosa. 2/3 consider that it is superinfection. 1/4 consider that it is a false positive for Vim, and only 21% that it is a true positive for Vim. So it missed some cases for Vim false or true positive, probably. Very interesting. So let's have a look to the results now and the interpretation. So the behavioral culture was totally negative for Acinetobacter baumannii. So you should know that after a few days of treatment, if the treatment succeed, you could have a residual DNA of Acinetobacter baumannii, but it is not a live Acinetobacter baumannii, but only DNA and residual DNA. So it is important to have it in mind. And in this case, there was a superinfection with Pseudomonas aeruginosa that was positive with Vim, Verona metallobeta-lactamases, and there was also for Proteus auxeri and ESBL. But that's it. So a problem to treat this kind of patients under tetracycline and colistin, and you see that probably colistin selects this Proteus, and probably rivastigmine was responsible for the emergence of Pseudomonas aeruginosa. So the solution for treating these patients could be to pursue colistin and probably to use cefiderocol in this case. You see that the MIC was quite good. One. So you should have in mind the false positivity of some MPCR after a few days of treatment, and that probably it is important to take into account this point when you are choosing the antibiotic for a superinfection. So here is the table for looking to all the molecules. You should have in mind that for Astreonam avibactam, Acinetobacter is not possible to use, and it is the case also for Ceftazidime avibactam Astreonam. You see that for Cefepime-Zidebactam, available in some country in temporary utilization, there is some Acinetobacter that are susceptible, but not all at all, not at all, not all the strains, and you should have it also in mind. And for cefiderocol, David Livermore told you about it. Another one, in order to finish my talk, it is patients with heart transplant recipient with a lot of complication, a septic shock, graft dysfunction, 15 days of ECMO, a candida colonization, treated for 10 days, and after 17 days of battle, of fight, he recovered, but there was an ischemic colitis that you see here. It was treated medically by cefotaxime, metronidazole, and parenteral nutrition, and the patients recovered. You should know that in in the CT scan that we performed, there was a thrombosis, a bilateral venous thrombosis at day 19. At day 26, he was successfully extubated. He was very conscious, no catecholamine, and he was still under hemodialysis, but the diuresis was good, 3 liters, so we were supposed to wean the patients from hemodialysis. He was transferred to intermediate care. The temperature was 38 degrees Celsius. The leukocytes was slightly increased, and the CVC and hemodialysis catheter were removed at day 26 without local sign, no pain, and 1 blood culture was taken because of 38 temperature. And unfortunately, 1 day after, we know that the CVC grew with 10 to the 4th Pseudomonas aeruginosa, 10 to the 3rd Enterococcus faecium, and the hemodialysis catheter grew to 10 to the 5th Pseudomonas aeruginosa. We performed monoplex PCR, and for both strains, there was NDM positive carbapenemase for Pseudomonas aeruginosa. My question, 1 blood culture was taken, and after 24 hours, it was negative. The patients were afebrile after catheter removal and well. So my question will be, do you treat these patients? And the treatment will be colistin, fosfomycin, vancomycin, for example. Or do you perform only a watchful waiting attitude? So in this case, what do you do? So let's have a look to your answer. I think it is very interesting and very important. Oh, interesting. Almost 1/3, 2/3. Treatment, not treatment. So it is it is an issue. It is very difficult. This case happened 1 month ago. So I have not the final answer. But you should know that if you look to patients with a catheter that is positive with Pseudomonas aeruginosa, if you are not treating the patients, you increase the risk of subsequent bloodstream infection. It was a study published in 2012 by a Thailand team, and you see that the risk was clearly higher with this kind of non-fermentative gram-negative bacteria in case of positive culture with catheter without positive blood culture. We perform another study with the outcome REA group looking to this problem, and we match patients treated and not treated when we are not able, even for Pseudomonas aeruginosa, to see a difference in mortality or superinfection due to a treatment or no treatment. So to treat the patients, we can say, yes, he is very immunocompromised. The temperature was 38 degrees Celsius. The microorganism is a non-fermentative bacteria that is capable to create problems. Only 1 blood culture was taken and no more, and there was an history of femoral thrombosis, so probably a risk for this catheter to be infected. On the contrary, we can say, well, there is no recent prosthesis or device, no organ failure, no sign of sepsis. It is not a Staph aureus, and we know that for Staph aureus, there is really an issue on not treating the patients. No exit site of infection, 1 negative blood culture, and finally, vancomycin and colistin are nephrotoxic for these patients that is weaned to antibiotic for hemodialysis very recently. So we choose not to treat and to stop antibiotic in this case, and it was a month ago. And after 4 weeks, there is no problem. The patients had no new Pseudomonas aeruginosa infection. The femoral thrombosis disappear. We look at it, and he was transferred to a rehabilitation unit. And I think it was one of the options that is feasible. So my conclusion for this case is for DTR organism, clearly discuss the need for a real treatment. And probably in some cases, if the patient is not too severe, probably a watchful waiting attitude could be discussed in some cases. So it was my last slide, and thank you for your attention.
Thank you, Dr. Timsit. It was a wonderful session with case studies, and it was an ideal companion to Dr. Livermore's talk. So whatever points that he brought out, they were excellently put into practice with the cases that you showed. They were all extraordinarily difficult ones, but the choices which you told and the explanation which you gave was really an excellent demonstration of how a master clinician would put into practice all the theory behind it. At the same time, I would say that there is a certain art, um, but there is a science behind the art too. So I think as clinicians, we need to really hone on our skills on both aspects of it, read the literature, be abreast of it, but also practice it in our daily ward rounds and in our daily work. I thank you once again. It was a wonderful presentation, and we'll need to go over it again. I would request if we could have a recording, because this was a really wonderful presentation. It was something which we should review again and again to get into the fine points of it, especially the one where the residual DNA was detected of the Acinetobacter was quite a nice message over there that we should definitely look for super infections and don't keep thinking that the old ghosts are still around. Thank you very much. With
Thank
that,
you.
I'll turn it over back to the organizers.
Thank you. Thank you. Thank you so much. Thank you, Professor Jean-Francois Timsit, for that amazing masterclass. And using a
Thank you very much.
Mentimeter was amazing, because, we actually learned during the process that we don't have to incubate it and practice it later. And the amazing questions which were brought in made so much clinical and teaching experience for all of us. And I love the watchful waiting, because knowing the patient and knowing your clinical skill is as important to practice the watchful waiting. Otherwise, one just rushes in where strong people like you may not. And I'm happy that many of our respondents did talk about watchful waiting. And that's really what one would expect. And let's hone our clinical skills, and let's keep meeting you and Professor Rajiv Soman again, so that we learn every time from you and Professor David Livermore. Thank you. Thank you so very much.
Thank you very much.
It was a pleasure and an honor. Thank you. Ladies and gentlemen, I'm sure you're absolutely enjoying this session as much as we are. It's such a scientific feast. And now we move forward to another giant, and that's Professor Thyri Nas, a great friend and an amazing person who will be delivering a talk on rapid diagnostic innovations, tackling extensively in pan-drug resistant microbial threats. And to moderate the session, we have another giant, Professor V. Balaji from India. He's the Hilda Lazarus Core Research Chair. And to welcome him, we have another dynamic PI of Dash to Protect Antibiotics, Professor Shoaib Jankwala. Professor Shoaib, please introduce yourself and then do the honors.
Yes, sir. Am I audible, ma'am?
Yes, yes, you are.
Okay. Very good evening. Myself, Dr. Shoaib Jankwala. I am professor in Department of Microbiology at Newton Medical College and Research Center, which is affiliated with Shakalchandra Patel University, which is based in Gujarat, India. I am also medical education unit coordinator and antimicrobial stewardship program principal investigator at our institute. I am very grateful to Dr. Meher ma'am and Sultan Qaboos University for initiating this study and enrolling us in this wonderful project. We are protecting tigers, but it's high time to protect the antibiotics. So those to protect the antibiotics is the project. And now for the next session, it gives me immense pleasure and honor to introduce our distinguished moderator for this session, Professor B. Balaji. He is an eminent microbiologist whose name is synonymous with excellence in research, leadership, and innovation in the field of infectious diseases and antimicrobial resistance. He is a professor from Christian Medical College, Vellore, India. Professor Balaji holds the Hilda Lazarus Core Research Chair, reflecting his preeminent role in research. His research interests span across critical areas such as sepsis, vaccine-preventable invasive bacterial diseases, and antimicrobial resistance, its mechanism, surveillance, and molecular epidemiology. Professor B. Balaji has made remarkable contributions as a principal investigator in several nationally and internationally recognized projects, including WHO surveillance program in Southeast Asia region on vaccine-preventable invasive bacterial disease surveillance network, the ICMR National Reference Center for Antimicrobial Resistance Surveillance for Gram-negative pathogens, and the Collaborative Center for Excellence and Center for Advanced Research on AMR, Pharmacokinetics, and Pharmacodynamics under the ICMR. Professor Balaji's outstanding contributions have been acknowledged globally. He is an Indo-US Science and Technology Fellow at Tufts and Harvard Medical Schools. He is also a Global Infectious Disease Research Fellow at the National Institute of Health, USA, and a recipient of the Charles C. Shepard Science Award from CDC Atlanta, USA. With over 545 peer-reviewed articles and more than 12,500 citations count with an H index of 59, such a remarkable achievements showcase his power of dedication in research. We are privileged to have such a visionary academic researcher today. Please join me in welcoming Professor B. Balaji, our moderator for this session. Over to you, sir.
Thank you, Sohaib. Thank you, Meher, for including us in this prestigious international symposium on antimicrobial stewardship and One Health. I could see huge number of people attending this session, and the well-accomplished speakers are lined up here. So with that introduction, I would like to kindly introduce Professor Terry Nias, who is a professor in medical microbiology and the head of INSERM research team, RESIST. And he has more than 420 publications with H index of 72 and 4 patents for his credits. And he was highly cited researcher in the Clavirate ranking of 2022. So there is no doubt he is a very well-accomplished professor and great teacher. So we'd love to listen to him. Please, Dr. Professor Nas.
Thank you very much for this very kind introduction. I'm very delighted to be here to listen to all these nice talks and to share also some of my experience related to AMR. So I will try to Do you see my slides?
Yes, sir.
Okay. So again, welcome everyone. So here are just my conflicts of interest. And this is probably a slide that you have seen many times. It was one of the very first reports that really mentioned the crisis we're going through and even how worse it could get if nothing is done. And maybe one thing that people don't have read, it's that Jim O'Neill gave us also some clues on how to curb with this problem. And one of the key issue that he indicated was rapid diagnostic. And rapid diagnostic, it's useful for the drugs, because at one point we will have new drugs arriving, and they're here, as we have heard from Professor Livermore and Jean-François Timsit. So we have to use them very well, and to use them very well, we need to infer the resistance mechanism, but we need it also for surveillance, and surveillance is very important because at one point we have also to inform the public about the crisis each country is going through. So rapid diagnostic is very important, and in France, it's really one of the key component of the fight against this multi-drug resistant bacteria, because we have a strategy called search and isolate, which means we have to look for these multi-drug resistant bacteria, mostly carbapenem resistance, in order to reinforce hygiene, to have dedicated staff, and even in some hospitals we have cohorting units. But also, as we have heard just by Jean-François Timsit, rapid diagnostic is very useful also to antibiotic stewardship, because with these novel molecules, we know that some will be active against KPC, OXA48, or metallobeta-lactamases. And we have also heard that a patient that is colonized by a multi-drug resistant bacteria may get eventually infected. So Jean-François Timsit said 15%, but in other studies, they come up with 40% of the patients that are colonized get infected. And then, of course, there is, even though molecular testing is expensive, there is cost saving, reduced moral cost, and avoids patient care. Another two important papers is that just came out recently. It's the World WHO bacterial priority pathogen list, for which we need new antibiotics. And of course, carbapenem resistance are top chart list of these bugs. And the recent report released by WHO on the GLASS indicates that among all the resistance mechanisms that are currently emerging, carbapenem resistance is really the one that is emerging a lot. In Klebsiella, it's 15% over the last 6 or 7 years, and in E. coli, it's about 12%. And Acinetobacter, as we heard, is also a key pathogen. So carbapenem resistance is really a key player in antibiotic resistance. So carbapenem resistance is something that we know for a very long time. As soon as carbapenems have been introduced, we were selecting sometimes through therapy a bacteria that became resistant to carbapenems, and this happens through impermeability problems and an enzyme that hydrolyzes very weakly carbapenems. This is, of course, a problem for the patient because these bugs are almost impossible to treat anymore. They're highly impermeable to any drug, but there is no epidemic dissemination. And these chromosomal mutations have a high fitness cost for the bacteria. So as soon as you stop antibiotic therapy, these bacteria have the tendency to disappear from the hospital settings. With carbapenemase enzyme that hydrolyze very strongly carbapenems, it's different because they're coming with highly epidemic clones. They have so-called high-risk clones. They're plasmid encoded, so they spread very easily in hospital settings. And this is the dilemma that we are facing from time to time in the hospitals. You have 6 bacteria that are highly drug resistant. Most of them have reduced susceptibility to carbapenems, and yet they are not equal. And of course, to keep a long story short, if you look at this, you would say, okay, these bacteria are difficult to treat. Maybe one is susceptible to ceftazidime, so we could use ceftazidime, and so on and so forth. But basically, we need rapid diagnostic tests just to infer which one is a high-risk clone. So we have 5 carbapenemase producing isolates and 1 that is a CTXM15 with impermeability. And in France, CTXM15 plus impermeability, standard contact precautions for hygiene, for infection control is sufficient, whereas for all the other ones, we need to reinforce hygiene. So it's very important to know what the mechanism is underlying these resistance phenotypes, because the consequences for infection control are different. But this is not the only reason. The other reason, and Jean-François just explained that, and David Livermore as well, said that according to the carbapenemase that you have in your bug, the treatment will be different. I'm not going to go through all these antibiotics again, but just an example, if you have KPC, it's ceftazidime avibactam. If you have OXA48 alone, it can be ceftazidime or even aztreonam, whereas if you have OXA48 plus ESBL, it's ceftazidime avibactam, and for MBLs, it's more complicated. It's aztreonam avibactam and so on. So knowing which enzyme is present will allow you also to implement the right antibiotic therapy. So when we look at the literature, there are many tools now out there that you can use to infer whether a bacteria is producing a carbapenemase or not. You have phenotypic tests. Some work quite nicely, but they take 24 to 48 hours, which is way too long for at least infection control management in the hospital. Then you have carbapenem hydrolysis tests. There are many commercialized now. You could use them and they work quite nicely as well. But again, they don't detect all the carbapenemases. Then you have molecular tools. Molecular tools, we've heard, you have many different ones, and we will see a few of them. They work also very nicely, but again, you will only detect what you're looking for. And then what I consider for at least confirmatory testing, the best to choose is lateral flow immunoassay. And if you look at all these assays and you compare them and you look at the time to results, no doubt lateral flow immunoassay provides you a result in 15 minutes, but in most of the cases when it's positive, you get the results in generally 1 to 2 minutes. The price, of course, those are commercially available tests, so there is a price, but again, compared to molecular testing, it's way cheaper. You don't need any cold chain. Room temperature is fine, whereas for all the other ones, you need enzymes that have to be stored at -20 or +4. You don't need electricity. You don't need trained personnel. I mean, we're all experts now in lateral flow immunoassay because we all had to swab our nose and do some COVID testing at one point. And the sensitivity and specificity are very good, and I will show you a few papers that clearly show that the sensitivity is even better than molecular techniques. Again, all these assays, they work quite nicely, but they all have limitations. And in order to use them, you have to know these limitations. Limitations is basically you only detect what you're looking for, and sometimes you have sensitivities that are not too good. So why lateral flow immunoassay? Because lateral flow immunoassay, it's really a very easy test to do, and you can do it everywhere. We have even collaborators in sub-Saharan Africa. They have no electricity in their lab from time to time, and yet they can infer whether they have carbaphenemases or ESBLs or other enzymes. It's affordable, it's sensitive, it's specific, it's user-friendly, you don't need any training, it's rapid, less than 15 minutes. You don't need equipment, and it's deliverable. And you have very long shelf life at room temperature. And for those who visited sub-Saharan Africa, sometimes room temperature there can be 35 to 40 degrees. So they're quite robust. And these are the assured criteria from WHO. So it's one of the only assay that really fulfills the WHO assured criteria. And there are many assays out there. Here are just a few of them that are commercially available. That once detects the 5 main carbaphenemases, detects all the ESBLs of CTXM family, and who detects MCR. And the reason I brought those 3 up is because those are the targets that are also detected by multiplex PCRs, such as the one that Jean-François Timsit mentioned, BioFire. But there are many more of these tests available. There is one that detects VREs, Van A, Van B. There are OXA23 strips, OXA23, 40, 58, 140, all the oxacillinase from Acinetobacter, GES, PER, VEB. We heard that VEB may infer, and PER may infer cefiderocol. So these assays are available. They're RUO, which means research use only, but they're available to help you assist diagnostics. And this is exactly what we're doing at the French National Reference Center. Before lateral flow immunoassay, we were doing PCR. Now we're doing lateral flow immunoassay as the first intention, starting from an antibiogram. When it's positive, we sequence the isolate. This is for epidemiological purposes. If it's negative, but the antibiogram is compatible with the CPE, we do hydrolysis tests, and this helps us to catch maybe the minor carbaphenemases, such as OXA23 and others in this assay. And per year, we perform 5,000 tests, and most of them are correct. We miss a few carbas by lateral flow immunoassay, but we catch them by hydrolysis tests. So this is very good, and this has now been introduced into the guidelines of the French Health Society, where lateral flow immunoassay is advised to do the confirmatory testing. So can we do directly on clinical samples? This is, of course, a very important question, because we need to be able to treat very quickly. So here are just a few examples. We could have added also some respiratory samples, but basically, classical way is you do sampling, you spread, or you make a culture, then you do antibiogram, and then you reach the result 48 hours afterwards, and then you can do your favorite immunochromatography to infer the presence of an enzyme or not. You can speed up by doing testing directly on growing cultures for rectal swabs. Usually you use chromogenic media, selective media, and you can do confirmatory testing. And the same for urine samples. You could do the same, and you could have already an idea of what is going on. But can we do more? Can we work directly on blood cultures? Can we directly work on urine samples or blood or rectal swabs? Of course, when lateral flow immunoassay was commercially available, many people thought, oh, we can use them directly on blood cultures. And here are just a few examples of papers where they used these tests. There is a lot of hands-on time, because you have to remove the blood, you have to centrifuge, you have to wash, you have to lyse and wash and centrifuge again. It's a lot of hands-off time, but in most of the cases, they showed that you get a very good result on blood culture. And the result was even better than molecular assays, such as the one from Cepheid, because unlike Cepheid that does not detect IMP2 variants, CARBA or lateral flow immunoassay detects all the IMP variants, which means it gives a better result. And in Singapore, they even evaluated this assay against whole genome sequencing, and they found 97.7% agreement between the two techniques. So a rapid assay that allows you to rapidly infer the presence of enzymes that hydrolyze your favorite molecule, such as carbapenems. And of course, there are commercially available assays now that are also available, that you don't need to do all this big hands-on time, which allows you to have in less than 5 minutes your samples on the strip, and in 2 minutes later a positive signal, and it works perfectly well with CTXM and also with CPEs. What about molecular tool? We heard from Jean-François Timsit that molecular tools are very useful, especially for respiratory samples. And indeed, when you talk about molecular tools, you always think it's much faster, which is not necessarily the case. Lateral flow immunoassay takes 15 minutes, molecular takes 1 hour. It's more accurate, highly sensitive and specific. Yes, it's true, but you also detect, as we heard, some remaining DNA that may lead to a wrong diagnostic. It's easier. Well, that's not always the case. Some are very easy, are plug and play, but not all of them are like this. And of course, they are perceived as more expensive, which is the case. Of course, they are more expensive, but with a medical added value, this is a price that many institutions and many hospitals are ready to pay. So talking about molecular, most of the molecular assays are polymerase chain reaction-based, PCR-based assays. We have the PCR assays that are considered as point of care. And the best example is Cepheid PCR, which is a small cassette which can detect up to 5 targets. So it's something that is quite limited in number of targets. And then you have something that is much broader, which are high multiplex, more called syndromic PCRs, which allows you to detect many, many pathogens, viruses, fungi, and bacteria, and also some resistant genes. So according, of course, what you're looking for, you can use either one or the other. The ones that are the most used now, at least in many countries, is the syndromic PCR. Syndromic PCR, you have many different ones. We have heard about the respiratory panel, pneumonia panels, we have gastrointestinal panels now, meningoencephalitis, bloodstream infections, also urinary tract infections. Basically, any biological samples now, you have multiplex syndromic panel that allow you to detect the most important pathogens, and in some cases also the most relevant resistant genes. And in fact, when you look a little in the literature now, and if you go to several congresses such as ESCMID or in the US, you see that there is a big blooming of these assays. And really, it's a big market, and the market is developing very rapidly. You have, of course, some that are more present, such as BioFire from bioMérieux, or ePlex that has been now purchased by Roche. Both assays provide results in 30 to 90 minutes, and they have a panel of almost 40 targets that can be amplified. So of course, these assays have been evaluated, and this is just one study where these assays have been evaluated. It is a multi-center study. They did it on positive blood cultures, and on positive blood cultures, they could show that overall specificity and sensitivity was 98%, which is very, very, very good for these assays. But again, one limitation, and why the specificity was not that good, is that you detect only what you're looking for. And in some cases, there was a pathogen that was not included in the assay. And then, of course, you will not be able to detect it. And as Jean-François Timsit just said, OXA23 or OXA40, which is Acinetobacter baumannii specific oxacillinases, they are not detected by these assays. And then, of course, you will not see them, and you will miss them. But overall, at least for the targets that are included in the assay, detection is very good. So this is what is currently developed and implemented in many hospitals, but some people are already looking ahead of this. And one of them is Gianni Rossolini in Italy. He wanted to see whether we can use now real-time whole genome sequencing to infer the presence of bacteria in positive blood cultures. And he used the nanopore technology. It's a small device that looks like a USB stick where you load the DNA and you can run the result. And by doing this, he managed to get the bacterial identification in 2.6 hours. So positive blood culture, you do the extraction, load on the flow cell, you get the result in 2.6 hours. 2.6 hours is the time almost of a PCR. And if you want to have the resistome, he could get the resistome within 4.2 hours. So 4.2 hours is very compatible with the daily life of a laboratory. But again, you detect only genes and you don't detect expression. So this is, of course, something that you have to keep in mind, that even with PCR, you detect only genes and not expressed genes. But this is certainly something that will probably develop in the next future. Again, for bloodstream infections, we have many, many PCRs that have been developed. Some are simplex PCR, some are small multiplex, and of course we have the large syndromic panels, but most of them work on blood cultures. But the next step will be directly PCR or metagenomic on blood. And this, you have a few examples here, T2 resistance panel or Magicplex sepsis, which work directly on blood. No enrichment through blood culture. You do it directly on blood. Of course, it's something that you cannot do on every patient because in France, many blood cultures are negative. So you will not be able to waste these costly the tools on this. But for some patients, ICU patients for which the risk of bacterial infection is very high, it's very probably advisable to use this strategy. But when you compare all these techniques with what is currently available, of course, you have classical susceptibility testing, which takes 24 hours. There is many devices that have been developed to get a rapid IST. So rapid IST, you have rapid RAST, which is advocated by UCAST, but you have other techniques which can provide susceptibility testing results within 2 to 6 hours. So again, it's something that is compatible with daily life. You have, of course, the molecular tests that we have seen, which are very fast as well, usually 1 hour to a few hours. And then we have now the latest ones, the tests that are in development, and some of them have already been commercially available, which allows you to detect directly inside of the blood the presence of bacterial isolates. So this can be done by metagenomic or by PCR analysis. So to keep all these things together, so classical way to handle analysis of a blood culture is, of course, 24 to 48 hours. What you can do also, and there are many assays now, you can do directly MALDI-TOF on a positive blood culture, which allows you to identify which pathogen you are. And what we do in BSET, we don't do it directly on the blood culture. We spread the bacteria on a plate, let it grow for 3 hours for gram-negative, 4 hours with the gram-positives. And this allows us to give microcolonies, and these microcolonies we can then directly use on MALDI-TOF, and which gives us the identification of all the pathogens. We have seen that you can do syndromic PCR. It identifies the main pathogens responsible for blood-brain infection, but not all of them. You detect genes, 5 main CARBAs, CTXM, and MCR1. You can do whole genome sequencing. This is probably something that is coming up in the next few years, but it's going to be very costly at the beginning, but it's certainly a possibility. And then you have lateral flow immunoassay that you can do directly on blood culture. It takes 15 minutes. It detects proteins, so express the genes. And basically you have assays that cover all the genes that are also covered by the multiplex PCR. And I would even add, you have assays that detect also the oxalocarbaphenemases from Acinetobacter. And what we do also in our laboratory, since we spread the bacteria, every blood culture on a plate, we do biochemical tests to get all the carbapenemases that are missed by the CARBA5, and we do the lateral flow immunoassay that detects the 5 main carbapenemases. This way you have really a good picture. So this is just to show you that you have costly, expensive techniques, but you can also get around and have almost the same kind of results by using cheaper assays, and maybe they take a little bit more time, but at least are as good. And then, of course, what we need to know is whether a patient is colonized by multi-drug resistant bacteria. So basically, this is done by rectal swabs. You plate it on chromogenic selective media, what the colonies that grow. Sometimes you have to do enrichment culture. This is when we know that someone is coming from an area where the prevalence is very high. We don't take a risk. We make an enrichment growth in order to increase the chances of detecting maybe a bacteria. And then you do your favorite immunochromatographic assay or your favorite assay to infer the presence of a CARBA or an ESBL. Here, of course, molecular techniques are the most useful because they detect basically one bacteria present in the swab. It's again, that's where it's really the most suited. But even there, our Greek colleagues have shown that for ICU patients in their hospitals where the prevalence of KPC is very high, they use lateral flow immunoassay directly on rectal swabs. And by doing this, without pre-incubation, they succeed. They had 80% of detection sensitivity. And by doing 3 hours of incubation, they reach nearly 100%. So by doing 3 hours pre-incubation, you achieve 100% with lateral flow immunoassay. So it's comparable to what molecular assays can provide. So AMR is a world health problem. It's rising everywhere. And one thing that we know from the old Chinese is that being aware of a difficulty allows you to avoid it. And rapid diagnostic is really in the heart of this because it allows you to handle this problem in your hospital. Of course, you will not be able to prevent a patient that comes to the hospital that is colonized, that will get infected. You will not prevent this, but you will prevent the transmission from one patient that is colonized or infected to another one. So we have assays that are now highly efficient, they are rapid, affordable diagnostic tests, but always keep in mind that they are hands-on tests. They do not replace classical microbiology because we still need to test for susceptibility, and we just heard from David Livermore that KPC may evolve by mutation, and even though we consider KPC as a carbapenemase, when it mutates, it becomes resistant to ceftazidime avibactam, it also becomes susceptible again to carbapenems. And basically, in literature, there are cases where they have treated successfully these variants with carbapenems again. So we need to do susceptibility testing. It allows us to have an idea, but it's certainly not the way to go. So most are validated for the epidemiology, global epidemiology. None is perfect. Knowing the limits of these assays is very important because then you can really use them and have a critical viewing of results. They are rapid. We have very rapid tools now, which can provide results in very high, in a very fast manner. And as I said, lateral flow immunoassay, it's really an assay that is quite affordable and fulfills all the criteria of the assured criteria for WHO. We have syndromic multiplex PCR, which, as Jean-François also explained, they're highly useful because they allow you to detect very rapidly in complex matrices, and respiratory matrices are really probably the way to go because in there you have only a few bacteria which cannot be detected by any other mean. They are costly. This is one problem. So you have to use them to the best way in order to avoid that the costs explode. But for ICU patients, I guess everyone will agree that you need to have a rapid identification in order to put up the right antibiotic treatment. And of course, you can only use all these assays if you have a diagnostic stewardship and an antimicrobial stewardship program available. Doing diagnostics, fast diagnostics, without having all this, it's worthless because behind the result, there must be an action. And the action goes through antibiotic and antimicrobial stewardship. And these assays have to be well thought and have to be integrated in your clinical workflow. And this is one usually big problem, that there is a delay in prescription, there is a delay in sampling, transport to the lab. So this has something to be optimized because if you really want to provide a fast result, everything pre-analytical has to be very fast as well. And of course, the microbiology lab needs to function 24 hours out of 24, 7 days out of 27, including molecular testing, of course. So this is probably one limitation of the implementation of this assay, is that it has to be done in a timely manner in order to provide a result. Thank you very much for your attention.
Thank you, Professor Terry. It was an excellent lecture. Almost, it was like a literature review. You covered from the basic bedside test, point of care test, to the advanced directly from the blood, bypassing the blood culture. So it was really nice to listen to your lecture covering all the aspects. Especially you focused more on the test which can be easily accessible and affordable for a low middle income countries. So really I appreciate for sharing a great deal of information in that area. I think a lot of people has sent their appreciation showing all those informations. So one point which I would like to share at this place is, this is an antimicrobial stewardship symposium. So the basic foundation for antimicrobial stewardship is you need to have the evidence for choosing the right antibiotic. If you want to choose the right antibiotic, you need to have the culture positive and you need to have the resistant mechanism. And Professor Terry has put up on a nice heat map. I think everyone should know that heat map, and every microbiologist should be by heart know that heat map for every enzyme, which drug works and which drug doesn't work. So that kind of a matrix, if they don't know, they can't choose the right antibiotic. If you don't choose the right antibiotic, then the mortality morbidity is going to be high, and it's not a true antimicrobial stewardship. So for a true antimicrobial stewardship, you need to have a good diagnostic stewardship. For true good diagnostic stewardship, definitely rapid tests are very important, and those rapid tests should be accessible and affordable. And especially in Indian settings, I should say that even NG Biotech lateral flow assay is not accessible in India. It's really pathetic. We do have a couple of other things. One is very expensive because imported from Germany. Another one is they're indigenous, but they have not reached out to many places, still restricted to cities. So with that, I would like to invite people to ask questions. And Dr. Meher, can you help me if there are any questions?
Thank you.
I
Thank you
saw
so
one
much.
question, doctor. One person has asked, what is the limitation of lateral flow assay?
The limitation is the number of bacteria. Basically, you need to have at least 10 to the 5 bacteria in your sample. So it works perfectly well on most urinary tract infections. It works, of course, on positive blood cultures. And for rectal swabs, of course, you need probably to have enrichment culture, because if you have only one bacteria on your rectal swab, you will not detect it. So you need to enrich this population. But in Greece, they used it on ICU patients. And these ICU patients, they all received antibiotics. And because they received antibiotics, they naturally enriched their microbiota with their multi-drug resistant bacteria. So that's why they had such a good result. But if you take someone a tourist that travels to an area and that gets colonized, it will probably not work. So this is one limitation. It's this sensitivity, of course.
Sure. Thank you, doctor. I wish you would have spent little 1 or 2 minutes more on one of the beautiful slide pulled out from the journal Antibiotic, where you showed the phenotypic MIC testing, which can give you the MIC within 5 hours, like reveal, Vitec reveal, then quick MIC, accelerator pheno. So I'm looking in the next 2 to 3 years, majority of the labs in the developed nations, they may have the same day identification of the bacteria, and within 5 hours, the MIC of every antibiotic. So once those in place, then the antimicrobial stewardship will be the best successful reward which it will be fetching us. Until then, we have to hold on, because still it takes time. As as you mentioned in the
Yes.
last line, the microbiology lab has to work 24/7, 365 days. Otherwise, the real benefit will not go to the patient.
Yes, but I agree with you. This is very important to have rapid MIC. But according to what we believe, and I know David Livermore believes the same, is that MIC is not everything. Because if you have an OXA48 producers, even though it's susceptible to carbapenems, the best therapeutic choice is ceftazidime and not carbapenems. So MIC is important to treat, but the resistance mechanism underlying whatever reduced susceptibility is also very important, because we know that if you have a susceptible isolate to carbapenems but produces a carbapenemase, carbapenems may be not the best choice for the treatment. So I guess it has to be a combination of the two. That's why diagnostic stewardship, it's really to have a whole program of diagnostics that will allow you to really implement the treatment to the best.
Yeah, as Dr. Terry was mentioning about the importance of resistant mechanism, I would like to bring to your attention that these days the newer beta-lactamase inhibitor, majority of them, all the Avibactam, Darlobactam, everything has got, in addition to the beta-lactamase activity, enhancer activity, where it binds to PB2 or mostly on PB2. So that is another aspect which you need to know, whether there is a mutation in the PB3 or in PB2, which is very rare, but PB3 is very common. So yes, I totally agree with the Professor Sherry that we need to know the exact resistant mechanism for individual organism to give appropriate drug. So since there are no other question and we are running a little late, I would like to thank once again Professor Terry and thank Meher and Raman Sardana for inviting me to be part of this excellent session. Thank you very much.
Thank you very much.
Thank you. Thank you. We had a masterclass yet again. We're really very, very happy with the way the conference, the symposium is progressing. We're learning more and more and understanding the value of rapid point of care tests, and really in an unequal world, increasingly unequal world, if we have point of care diagnostics like LFIA, we're going to promote diagnostic stewardship, antimicrobial stewardship, and try to make the world less resistant, maybe. Of course, if we have cheaper drugs to treat these antimicrobial, these extreme drug-resistant bugs, would have been a dream come true. But Dr. Taheri Nas, thank you so much, and we'd love to collab. We've been testing these rapid diagnostic tools in our center as well, and we would love to promote this and share it in our Dash to Protect antimicrobial group, so that we can map, you know, the susceptibilities, the CREs, the ESBLs. And I was happy to see that you had some research, AMC, some research tools for detection of AMC as well, which is again very important for appropriate antimicrobial treatment and promoting antimicrobial stewardship. So we'd love to hear and discuss with you more regarding this. But in the interest of time, we're just going forward. Thank you, Professor Balaji, for that excellent moderation. We learned with that discussion which ensued, and really, really thankful to both of you. Thank you so much.
Thank you.
Ladies
Thank
and
you.
gentlemen, thank you. Thank you so much. Ladies and gentlemen, the last talk, unfortunately, Dr. Badrul Hassan is not here, but we're very, very happy that we have Professor Angarat Davies, again, a very good friend. I'm really delighted to have her here, and she'll be discussing stewardship in Wales. To introduce her, we have, again, a very distinguished moderator, Dr. Saif Al-Abri, who's a senior consultant in infectious diseases, previous to which he was the DG Health in MOH, an experienced person indeed. And to welcome him, we have yet another vibrant principal investigator, Team Dash, Dr. Ashima Singh. Will you please introduce yourself and then do the honors, Dr. Ashima?
Yes, ma'am. Thank you. Good evening, everyone. It's a pleasure to welcome you all to the International Symposium. I am Dr. Ashima. I am currently Assistant Professor in Department of Microbiology at Sri Ramurthy Smarak Institute, Bareilly, UP, India. And I would like to thank Dr. Meher ma'am that she's given me this opportunity to be associated with such great learning academic feast. And I would like to, I'm honored to introduce our distinguished guest, Dr. Saif Al-Abri. He's a senior consultant in infectious diseases at Royal Hospital, Muscat, Oman. Dr. Abri is a renowned leader, having led Oman's national technical team during the COVID-19 pandemic and served as the national focal point for international health regulations for Oman from 2014 to 2022. He brings a wealth of global experience as an international advisor for the Royal College of Physicians of London. A dedicated academic leader, Dr. Al-Abri has chaired the Governing Council of Oman Medical College and currently serves as a council member for the National University of Science and Technology. His research contributions are prolific, with over 140 scientific articles, and he is an associate editor for several esteemed medical journals. We are privileged to have Dr. Saif Al-Abri join us and moderate this session. Looking forward, sir. Over to you, sir.
Thank you, Ashima. And I welcome Dr. Saif Al-Abri for doing the honors. Dr. Abri, we're unable to hear you. Do we have Dr. Saif Al-Abri with us? Dr. Mr. Yes, I can see. Oh, excuse me, Dr. Mr. Doshi, Dr. Saif Al-Abri has just messaged me that he needs to be moved to the faculty lounge. He doesn't have the privilege to speak. Will you please do the needful, Ms. Shalu?
Yeah, we'll do
Mr.
that.
Yeah, Dr. Saif Al-Abri. Dr. Saif, we're working on it. Audience, Professor Angarad, Dr. Saif, I'm very sorry
Already
about
done.
this.
Already done that.
Done?
Yeah,
Dr.
yeah.
Saif,
He's
okay, does he have the rights to speak and
yeah,
to
yeah.
open?
He's rejoining in.
All right, all right. Thank you.
Good evening.
Good evening, Dr. Saif. Welcome, most welcome.
Thank you very much, Dr. Rizvi, and thank you very much, Dr. Singh, for the introduction, and very thankful to all of you for organizing this excellent meeting. So it's a great pleasure to welcome Professor Angard Davis, who is professor. She is a professor and honorary consultant at Swansea University Medical School. She is also the clinical director for publishing and engagement at the Royal College of Pathologists and education and training lead, Wales AMR Health Delivery Group. She is vice president of Medical Women's Federation, and she has many fellowships, including Royal College of Pathologists, Royal College of Physicians, Learned Society of Wales. And in fact, I have looked her up online, and she has great work that has been done in Wales and in the UK, and she is really a leader in the AMR and stewardship. So we look forward to hear from Professor Davis about the experience from Wales, the stewardship in Wales. The floor is yours. Thank you.
Well, hello everyone, and thank you very much for the kind introduction, and especially to the organisers for inviting me to present here today. It's a real privilege to be able to join you at such a wonderfully informative symposium. It's been really super. Now, let me try and share my slides. Have they come up now? How's that?
Yes, but could you please make it in a presentation mode?
Okay, to me that is in presentation mode. Has it come up for you yet?
Not yet.
You can resharing it. Just stop sharing it and then do again.
Just a second, I have to go to another screen, I think. Now. Right, I shall try again.
Still not the full screen. Do it in a presentation mode.
I don't know why it's not full screen, because on my screen it is full screen.
Okay, what you do is you just stop sharing the screen. Now you open your presentation and put it in a full screen mode. Don't share it now. Don't share the screen now. First, you open your presentation. Keep it in a full screen mode. Are you able to do that?
I'm not sure why we have this problem. Just a second.
You know, very often what we do is, rather than sharing the screening icon, clicking on that, there's this book icon left of that. That usually works for us. But let's see, maybe it's working now.
Yeah, put it on a presentation mode now.
It's still in presentation mode for you.
Yeah, but it's not at the full screen. Yeah, make it that.
Can you show the photo, Mr. Doshi? If you could just take a screenshot, tell Dr. Angarad which icon to click next time when she shows us that, because she's in that WhatsApp group.
Let me just see.
Angarad, will you just click on that book?
Yeah, just now you go down. Take your cursor to the down right hand side down.
No, I don't think. Wait a minute.
Don't worry, it'll be okay. Just take the cursor to the book. I mean, I believe in the book. I don't know what about Mr. Nitish.
Yeah, that's not how mine is set up. Just a minute.
Okay, it's fine.
Or ma'am, shall I share her presentation? I have a presentation.
Yeah, I think
Nice
that will be a good.
presentation.
Angarad, what do you say? Is it okay if we run the presentation from our end?
You could do. The only thing is, because there's quite a lot. I don't understand why it's not sharing as it normally would. Let's just try
It does
it
that
one more.
sometimes. It always does that sometimes. Let's see now.
This is fine. Now what you do is you take the cursor on the right hand
Mr.
side
Nitish, take a
bottom.
photograph. No, take a photograph and show where she needs to click and share it in that WhatsApp group. Just take
Okay.
a photograph and
I've clicked the photograph. I'm going to the WhatsApp.
yeah, and just point which icon she needs to press. Yeah. So mark that icon.
Now, how's that?
Yes,
Does it
perfect.
come up now?
Perfect.
Okay, it was the setting that
This
the
is fine now,
laptop was
yeah.
on. Right, great. So I'm sorry about that delay, everybody, and thanks for bearing with us. Right, as you've heard, I'm a clinical director at the Royal College of Pathologists, and I'm a previous vice president of that college. By background, I'm a consultant microbiologist, and I have a special interest in education in the field of antimicrobial stewardship. And amongst other roles, I lead the education and training work stream of the Antimicrobial Resistance Human Health Delivery Group for Wales, which I'll talk about a bit later. And I've been a council member of the UK Academy of Medical Educators. So we're going to have a change of tack now, because my presentation, as you might have guessed, will have an educational theme and quite a different emphasis from your previous very expert speakers. So I hope that this will complement those talks and still be of interest. So this is what I plan to cover in the next 20 minutes or so. I know that with this audience, I don't need to spend time elaborating on why antimicrobial stewardship is such a critically important element of our practice. I know that you're all more than familiar with that. As well as diagnostics and therapeutics, which we've heard about today very wonderfully, another important part of our job is to educate other healthcare workers to use antibiotics responsibly. But are we doing this important job well enough? So I'm going to review the policy landscape for AMS education and how we can seek to measure the impact of our activities, and then explore the evidence that exists for the most effective ways to train our students and staff as we ought to, look at the published evidence on best practice in continuing CPD for healthcare workers, and finally I'll move on to share our experience in a case study of how we applied these principles in our setting. So I'm sure you're all familiar with the World Health Organization Global Action Plan on AMR. It's a few years old now, but the main pillars still apply. I've listed them here. And one of these pillars is education and training. As well as this, of course, we all have our own country action plans. The UK, for example, has a 20-year action plan. We're now in the second 5-year segment of that 20-year plan. So last year, in 2024, our second 5-year national action plan was published, which runs until 2029. Now, in this action plan, there are 4 main themes, which are shown on this slide. The theme that I'm interested in is the one in the top right of this slide in the orange. Within optimizing the use of antimicrobials, we have health and social care training. And this is represented in the UK 5-year action plan in commitment 5.1, which for the first time says it will be required for all of health and care workers and students to complete appropriate AMS training. And this is a great step forward for us because we haven't previously had that spelt out as a requirement as opposed to simply a recommendation. And you'll also see that we have a target associated with this, target 2A, which is that it says that we aim to increase healthcare and social care worker knowledge on AMR by 10% by 2019. And this quantified target is also a new element, which begs the question of how do we measure a 10% improvement in healthcare worker knowledge on AMR? Well, this is how it's proposed that we'll do this. It's going to be done using European Centres for Disease Control survey, which was last carried out across Europe in 2019 in lots of countries across Europe. And you can, if you're interested, you can read all the results of that online. But this survey consists of 7 very, very basic questions. This is for all healthcare workers, not only specialists working in antimicrobial stewardship. And in 2019, 59% of UK healthcare workers were able to answer all 7 of these questions correctly. So a 10% improvement would require around 65% of healthcare workers to be able to answer them all correctly. And that is how this is going to be measured, by rerunning this survey. So how are we addressing this in Wales, where I work? So Wales, for any of you who may not be familiar with it, is one of the 4 nations of the UK. It's in the west of the UK, to the west of England. It's coloured red on this map. It is, of course, the most beautiful part of the UK, and it offers you a very warm welcome, and I highly recommend a visit. All 4 nations of the UK have devolved health services, and this document here is Wales's response to tackling AMR, published back a few years ago now. It was called Together for Health, and it included actions for Wales specifically. And in the Together for Health document, they committed to employing antimicrobial pharmacists in all the National Health Service organisations in Wales to support antimicrobial stewardship in a specialist role. Now, at that time, antimicrobial pharmacists were quite a new concept. People weren't very familiar with them. There were hardly any of them existing in Wales. Since that time, they have become an extremely important element in antimicrobial stewardship in the UK, and I know in other parts of the world as well. Along with the microbiologists, they are the key practitioners involved. However, for a pharmacist looking at taking up such a role, there are some very demanding asks, and I've listed here some of the elements from their health service job descriptions. You can see that these include to influence medical consultants on the management of pharmaceutically complex cases, to challenge treatment choices, to deputise for microbiology consultants, and to interpret microbiology results to provide clinically appropriate advice. So really, I'm sure you'll agree that these are quite challenging requirements. And so it's perhaps not surprising that when this document was published, the new cohort of antimicrobial pharmacists who were being appointed, new to these roles, approached me to say, Help. We know about drugs and antibiotics, but we really have almost no knowledge of clinical microbiology. Can you help us by providing some training? So I did want to help, and this led me to explore a bit more the research underpinning continuing professional development of healthcare professionals. And in fact, if you're interested in this topic, the UK General Dental Council carried out an excellent and comprehensive review of the evidence on this topic. It's well worth a read if you're interested. And the literature shows that there are a number of principles for best practice for effective CPD for adult professional learners. And I've summarised the main findings here. One important aspect of good practice is relating the CPD course to the participants' learning needs. If it's relevant to the practitioner's daily work, it's much more likely to motivate and result in practice improvements. Secondly, there needs to be a combination of learning approaches, which should be interactive, such as case-based discussions and practical exercises. Thirdly, interactivity and interprofessional and peer learning. So peer learning can take a number of forms, such as peer feedback, peer discussion groups, peer interaction. And it facilitates best practice and is especially valuable for lone practitioners, which these antimicrobial pharmacists, especially at the outset, often were on their own in their health boards. They were the only ones in their hospitals. And peer learning has been shown to be more likely to lead to positive changes in practice. And interprofessional education is particularly beneficial in terms of promoting collaboration and teamwork. And finally, sustained support after completion of the course is another best practice feature, which I'm going to talk about later on. And I like to summarise these 4 points as the 4 I's: interest, interactive, interprofessional, and iterative for the sustained support. Despite all this evidence base, which does exist, adherence to these principles is patchy at best. This review in the BMJ identified 32 healthcare professions for which CPD was a mandated requirement, but found that there was very limited use of effective evidence-based methods to underpin all of this CPD that was going on. So a lot of activity, not using the evidence-based. So for our programme in Wales, we wanted to try to do better. And so with this in mind, in consultation with our pharmacists, we created a bespoke course on antimicrobial use, resistance and stewardship. It's a week-long course, it's intensive, it's face-to-face, and it's interdisciplinary, and it's attracted not only pharmacists, but specialist nurses, doctors and other groups of staff as well. This photograph shows you our latest cohort who came along last year on this course, which has been running for 10 years now. We aim to employ the evidence base to incorporate as many of the best practice features as we can through using the 4 I's that I've described. So first of all, it's designed to explicitly meet the needs of these learners, which was achieved by planning the course content in consultation with those learners from the outset. Secondly, it's as interactive as possible and uses all these elements which I've listed here to facilitate that. For example, we have a gram staining practical, which the students particularly enjoy. They look at gram stains and they relate these to the patient's clinical condition, the differential diagnosis and potential therapies. And these healthcare workers don't normally see the inside of a lab, so this really helps to improve their understanding of the whole diagnostic process and why the gram stain is important and how we can use that to help us, as an example. In between sessions, we use various games to keep people engaged and as icebreakers and to add a bit of fun. For example, some antibiotic top trumps games that we devised. The top trumps were a great success, and the Microbiology Society actually kindly funded us to produce them professionally as game cards. Thirdly, we make as much use as possible of interprofessional and peer learning. So on our course, we have both learners and tutors from as wide a range of disciplines as possible. there is plenty of evidence to support the benefit of interprofessional learning in healthcare settings. There was a Cochrane review, it's a few years old now, but still relevant, which found that most studies in this field found positive outcomes on several counts, including patient satisfaction, error rates, and especially team working, and was received very positively by learners. And the feedback from our course shows that this is one of the most highly valued aspects. They love to hear from different healthcare professionals, different perspectives, different angles on the same topic, as well as very positive feedback about the peer learning aspect, which I've already alluded to. And lastly, point number 4, the iterative point. We wanted to ensure that once people had attended this course, they just didn't just go home and forget all about it. It was very clear that those who were attending this course were highly engaged. They were very dynamic practitioners in their own health boards, and they were the ones providing training to all the health board staff locally in their hospitals in antimicrobial stewardship. And we wanted to find ways to harness this engagement and enthusiasm that they had to strengthen antimicrobial stewardship education across the whole of NHS Wales. And that's what led to the creation of AWARE, standing for All Wales Antimicrobial Resistance Educators. The idea was that we wanted to create a virtual, interprofessional, Wales-wide community of practice to share good practice, ideas, resources between our members. And by engaging this community, we could also build up a comprehensive picture of what training in antimicrobial stewardship was being provided in local areas across Wales and identify gaps. So we do that by using a website to share information and resources. It's at www.antibioticaware.com. It's freely available to anyone. There's no paywall or anything like that. And on this website, we store all of our shared resources, which are made freely available to educators, but also to medical students and others who want to use them. So these are just some examples of the resources on our website. We also have links to outside useful links, such as the UK Green Book for Immunisation, for example. We use an X account to communicate, for example, to promote the annual course. We've got a range of short animated videos covering basic topics for learners, that's called 1 Minute Micro, and a series of podcasts which have been created by our specialty trainees in microbiology. So it's been a great opportunity to support their learning as well. And so far, our trainees have been unstoppable. They've created nearly 60 episodes of this podcast on nearly every topic in infection that you can think of. They're really great, and they're available there freely to anyone on the website. So every year, we contact all the network members and ask them to provide us with information on the education they've delivered locally in their hospitals on AMS. And we use this to build up a picture of local provision, which we wouldn't otherwise capture. I've picked out this snapshot of data over the last few years, which shows that even despite the pandemic over 2020 and towards 2022, that period, our educators were able to reach more people for training than previously because of the rapid adoption of virtual platforms, making it easier for staff dispersed over rural areas to attend. And we were able to publish these findings in the Journal of Interprofessional Care. We've run various webinars showcasing members' educational practice, and we've branched out internationally. That started with a collaboration with the Royal College of Pathologists and the National Postgraduate Medical College of Nigeria. We ran a lecture series with them, which are available on the RCPath website. Those are freely available to anyone who would like to access them. And this year, we ran a global antimicrobial resistance webinar series with RCPath, with invited expert speakers from all over the world. Here are some of our expert speakers in a collage. And again, all of those webinars are freely available on the RCPath website. And we were here's the a poster showing some of the details of this project, and on the left here you can see the wide range of countries that our speakers, our expert speakers, came from. And we were very proud that this project was shortlisted for the UKHSA Antibiotic Guardian Award for a multi-country collaboration. This shows the team and myself at the awards ceremony in Birmingham in the UK. So overall, the benefits of this project have been using best practice in CPD to do an evidence-based approach for CPD for all our healthcare workers in Wales. We are able to cascade the knowledge that we teach our specialist practitioners annually in our in-person course to all healthcare workers in Wales, because they are the ones going out to the hospitals and doing this work locally. Practitioners can engage with the network, and this supports their own educational work, helps them to share good practice, and it enables us to capture educational activity. And this has been really useful actually in informing the Wales Antimicrobial Resistance Human Health Delivery Group, which I'll talk a little bit more about to finish. And lastly, on this point, I'd like to point out that the AWARE project started as an entirely grassroots initiative without a penny of funding. All of the original activities, the resources and the original provision were set up at no cost whatsoever, just personal time and commitment. And I know that Dr. Rizvi has her initiative DASH to protect antibiotics, which is also a labour of love and shows what projects can achieve with enough personal commitment. And I'd like to congratulate her and everyone else in that team involved on that fantastic project. So returning to our National Action Plan, where are we now with antimicrobial stewardship education in Wales? Well, we now have a Welsh Government-led AMR Human Health Delivery Group, which has an education and training work stream, which I lead. This work stream is charged with ensuring provision of training for all healthcare and social care staff in Wales. This is our sort of the map of what we're trying to achieve. We have 3 levels. We have the very basic level. We have the prescribers and pharmacists and also nursing staff and non-prescribing healthcare practitioners at level 2, so sort of medium level of expertise. And then we have our specialist expert antimicrobial pharmacists and so forth at level 3. So we have now expanded our work, and so far we've already established and put in place the boxes that I'm ticking off in yellow. So we have our course, which I've already described to you. That's our specialist level provision. We have a very comprehensive and quite detailed e-learning module for our prescribers and pharmacists in both the community and primary care and in secondary care. And I'm pleased to say that we have now, thanks to the wording of the UK National Action Plan, which requires all health and social care workers to be appropriately trained, we have secured an agreement that our level 1 training will be mandated for all staff. That was a big step forward. And our next milestone will be our level 2 training for non-prescribers, including nursing staff. These are some of the challenges that we faced. In particular, we had a challenge around the mandation of training. So in Wales, infection prevention and control training is mandated. AMS training was not. That meant that we were aware that even if we had in place good basic training for health or for all healthcare workers, it would be difficult to ensure that people actually undertook that training. So it actually helped us enormously when the National Action Plan came out saying that that training was from now on going to be required. So this is a reminder that the precise wording of documents such as action plans can help enormously. So if you have the opportunity to input into such documents, do try to use your influence to make them as firm as possible. And I've listed a few of the other types of challenges that we've encountered as well. Some of those to do with budgets, some of them to do with different stakeholders having different priorities, and some of them to do with sometimes the disconnect between different organisations. The last challenge there about diverse professions, I've included that, but actually I see that as a strength. As I've said, we place great emphasis on interprofessional learning, and we think that bringing the different professions together actually strengthens the training. So that's just a reminder about our National Action Plan requirement and how helpful that has been. That has really moved our project forward. So that brings me to the end of my presentation. Here's a summary of some of the resources that I've talked about. They're all free to access online to anyone who would like to do so. So if you think you'd find some of those useful, do go and explore some of those. And thank you so much for the invitation to join you today. It's been an absolute privilege and a pleasure to join in your symposium. And thanks for your attention. I'll stop sharing now.
Thank you very much, Professor Davis, for this enlightening, excellent talk, which is very, very informative. And it's very practical for all of us. And in fact, it takes effort to mimic what we have done. It's not the theory, it's the practice, and it's the dedication and perseverance which we have shown. I'd like to ask Dr. Rizvi, do we have time for a question or two to Professor Davis?
Yes, absolutely. Please go ahead.
Okay. Any questions from the audience? Because I didn't see a specific. If not, I have a question. I can start with my question.
Yes, please.
You are the co-author on the 2020 consensus paper that defined the 58 core AMR competences for all UK medical undergraduates. From your perspective as both a national standard setter and a frontline educator, what do you see as the single biggest challenge in practically embedding these competences into an already crowded medical curriculum?
Well, you're right. That is a huge challenge. When we produced that consensus document, we did so in the acknowledgement that it is, I suppose, an idealized document that we did not expect that every medical school was going to necessarily include every single one of those competencies. But we hope that they will do. There are two issues here. One is that in the UK, medical education at undergraduate level thus far has been slightly different in each medical school. Medical schools have their free, they must meet GMC standards, so they must meet the standard, but they do have some freedom in what exactly they teach and when, and they can't be, there's no absolutely standard course. Not all the courses are identical. Having said that, the GMC has now, since last year, introduced the medical licensing assessment, which is an effort to further standardise the content of all the medical courses. And we have had opportunity to input into the content blueprint of the MLA and include as much antimicrobial stewardship and antimicrobial prescribing and infection content as we possibly could in the MLA, because this MLA exam is a standard exam that all UK medical students across the UK must pass in order to graduate. And we all know that assessment drives learning, unfortunately, and so making sure that we had plenty of infection and antimicrobial stewardship content in that MLA has been absolutely critical, and that's what we have tried to do with every lever of influence that we could employ. So I hope that that will help to improve the situation.
Thank you very much for the question. I'm not sure there is another question, but I have another burning question from my side. In 2022, you published a report on the Wales Antimicrobial Resistance Education Aware Network that highlighted a fascinating finding. The pandemic's forced shift to virtual education allowed you to reach more staff with fewer teaching hours. So for you as a leader of the education and training work stream for the Wales AMR Delivery Group, how are you now working to blend the efficiency of the virtual model with the impact of the face-to-face engagement?
Well, I suppose that there's two strands to this. Our e-learning packages, our learning packages at the basic level and the level 2 are online resources which are available at any, people just access them online. We are keeping our specialist treat provision face-to-face because that's an intensive week-long course. In terms of the education that's going on all the time in the health boards, face-to-face teaching is reported by our target audience to be more engaging. The problem is, of course, that Wales is a very rural area of the UK. Hospitals are far apart. Antimicrobial pharmacists and other educators like consultant microbiologists are often based in one hospital, and the staff they want to reach might be in a different hospital. And so the rise of virtual platforms, which we're so used to now, but before the pandemic, we really weren't, that has allowed us for it to be more feasible to reach more of these staff who might like to attend in person, but actually they can't because they have to be at work in their particular hospital. There's too much travel time involved for them to come somewhere else. And sometimes even if they're within the same hospital, it's difficult for them to get away from their ward setting, but they are able to zoom into some teaching perhaps. And so it does really help us to reach a lot more staff. But there's nothing like the face-to-face engagement. So we still try to provide that as well in order to keep people motivated.
I don't see any more questions. So thank you very much, Professor.
Thank you.
Angarad.
Thank you for having me.
Thank you.
Thank you. Thank you so much, Professor Angarad Davies and Dr. Saif, for that excellent session and moderation. Professor Angarad, you're amazing. You've got down and dirty. You've looked at the problem critically. You've thought of yourself in the place of all the stakeholders. And you've created such a valuable content, which we would love to replicate in so many parts of the world. And it's been amazing. And I love the fact that it's been mandated, which really supports your cause. And you've included the interdisciplinary, which is beautiful because that's how it really should be. And people go back more enriched than just the theoretical aspect, but they understand the real life situation and they learn more, and it becomes more of a synergy. I love that word, synergy. And it really is an amazing experience you've given us. And we're so proud of the work you've done and would love to interact with you, collaborate with you, because we've got a very smart pharmacist group in Oman as well. And we would love to have that experience with you later. Maybe we'll connect with you. Thank you, Professor.
We'd love to. Thank you.
So impressed and so delighted with the wonderful work you're doing. The soul of Wales, you could bring in that to us. And we're so excited with the wonderful work you're doing. Congratulations from all of us.
Thank you. And the same with the DASH initiative is fantastic as well. Just so much commitment from everybody.
Commitment, yes, but the kind of body of work which you're doing is impressive. We'd love to emulate that. Thank you so much, Angarad and Dr. Saif, for that excellent moderation and those very penetrating questions. And now, ladies and gentlemen, we're coming to the highlights of today, where I welcome our young HOD, our dynamic Dr. Zaima Al-Jabri, who gives us a beautiful wrap-up and, of course, the vote of thanks. So, Dr. Zaima, the floor is yours.
Thank you very much, Dr. Meher. It has been a very fantastic evening, and we enjoyed all of us this symposium. So, ladies and gentlemen, it's my great pleasure, actually, and honor to deliver the vote of thanks at the close of today's enlightening and thoughtful and also thought-provoking sessions. On behalf of the organizing committee, I extend our deepest gratitude to all of our attendees today. First of all, our chief guest, the Dean Professor Rashid Al-Abri, and also guest of honor, Professor Sanjeev Singh, our distinguished speakers and moderators who have joined us from across the globe to share their expertise, insights, and also experiences on this critical issue of AMR and management of challenging super infections. A heartfelt thanks goes to Professor David Livermore for setting the stage with his insightful overview on the antibiotics, their clinical potential, and on the extremely drug-resistant gram-negatives. And we will not forget the horses for courses, of course, the various combination suggestions, and the final notes also on the sparing on the new drugs. And also to our speaker, Professor Jean-Francois Timsit, for his wonderful cases. He shared real-world case studies on managing highly resistant gram-negative infections. The interactive session was very wonderful. We enjoyed the challenging decision-making that we all face, the ID physicians, the microbiologists face in practice, with a lot of wisdom involved there. I would like also to thank Professor Terry Nass for the enlightening talk on the rapid diagnostics and innovations and their role in combating resistance. Very insightful. He inspired us on so many rapid tests that we could use also for low and middle income countries. Prof. Angela Davis for her wonderful and also inspiring presentation on stewardship initiatives in the UK, Wales, and also globally. The 4 I's in stewardship, best practices. We learned more about examples and resources. Thank you for sharing those wonderful examples, like the AWARE websites, among other websites and webinars. So I'm sure a lot of our audience today would be interested to actually have a look at these resources. And not to forget about our expert moderators from the DASH team, Prof. Raman Sandrana for his valuable moderation, Professor Rajiv for his also perspective and engaging discussions, Prof. Balaji for his also moderation and insights, Dr. Saif Al-Abri for his valuable contribution and engagement and important discussion and questions. Of course, to our dedicated members of the DASH team, Dr. Pranya, Dr. Shuaib, Dr. Maria Khan, Dr. Ashima for their introductions of our moderators, support, and also presence throughout the sessions. And we will not forget our event management committee. We are deeply thankful and grateful for you meetings and more, for their excellent coordination and professionalism that they showed today. They ensured smooth execution of the symposium. Thank you all. And I would like to extend our thanks to participants and attendees. Thank you very much for your active engagement on the chat. I could see that they were providing immediate feedback about the session, and we'd love to hear more about the overall also feedback from you after the session. It's very good. It shows a lot of commitment from your side on the advancing AMR stewardship and infection control. Your presence here was also very enriching, and this will also foster hopefully future collaborations to tackle AMR. Lastly, our sincere appreciation goes to the sponsoring companies, Advanced Healthcare Solutions and Business International Groups for their generous support, which they made this event possible and also successful. With that, it's a great pleasure also to welcome Dr. Ahmed Median, the Director of Clinical Solutions at Cepheid from East Europe, the Middle East, and also Africa. We truly appreciate your presence with us today and your continued support for our efforts in combating AMR. He will be delivering a very short talk on transforming AMR strategies, proactive prevention, and integrated collaboration. and he will be highlighting areas that are very critical to all of us in clinical microbiology and public health. And we look forward to hearing your insights, Dr. Ahmed. The floor is yours for your talk. Thank you very much.
Thank you so much, Dr. Zahima. Just a moment. Okay, I will be sharing my screen. Please let me know that. Can you see it?
Yes, we can.
Yeah.
Thank you. So thank you so much for inviting us to your estimable event. Really, it's a pleasure and it's an honor to be part of it. It has been inspiring all over the couple of hours or the past few hours, and thought-provoking symposium, actually, where we have our estimable speakers journeyed us together through the landscape of antimicrobial resistance, uncovering the diagnostic innovations. And what we have witnessed today reflects one undeniable truth, that antimicrobial resistance, it's not only a microbiological challenge, it's also a system challenge. And when we speak about that challenge, it's a challenge that demands from all of us a proactive and coordinated and sustained defense, especially when we see the rising trend to the known and used antibiotics, as reported recently also in the WHO Global Antimicrobial Resistance Report that issued in the beginning of this month. Professor Nass has reminded us in a very expressive and extensive way about the diagnostics and the innovations. And the diagnostic innovation here, it's really central to the antimicrobial resistance containment: fast, on-demand, accurate results, and the enabling clinically actionable results that really empowers the hospitals not only to diagnose, but also to prevent the transmission from the carriers or colonized cases. Now, that's really transforming how to control outbreaks and, in the first place, how to prevent it. The proactive approach, it's always means that we no longer wait for the infections to happen, we act before they do. And through the enhancement of the screening and the identification of the high-risk patients, so we can define the transmission, clogged MDRO sources in the hospital, and strictly implement the infection control measures following these results. This early identification of carriers or colonized patients, we can also definitely reduce the transmission and preserve antibiotic effectiveness as one of the main pillars, as well recommended by CDC, is the prevention and the limiting the transmission. And let's also to be clear about one important thing, which is prevention is not always about the patient safety, but also it's an economic wisdom. And the cost of a single outbreak that we can see here in this slide with the reference that can overweight months of preventive investments, where here the prevention pays both lives and save lives, and also in the resources it preserves through the reduction of unnecessary isolation, translating that into cost savings and safer hospitals from healthcare associated infections. And this paradigm actually shift from reactive infection control to proactive infection prevention, where the infections prevented in one less antibiotic prescribed. It is also very important to understand that every carrier identified in the hospital before the transmission is one chain of the infection that has been broken. And when the results come fast, definitely the actions will be definitely coming faster. And when the screening is targeted screening, I mean for the high risk criteria where these criteria applies, the resources definitely will be optimized. And in that case, the stewardship program will definitely succeed with combined the forces with the diagnostic stewardship. But it's always not only about the technology. The true strength of the response against antimicrobial resistance lies always in the collaboration across departments and different disciplines. Infection control, clinical microbiology, the stewardship teams, and the hospital management, public health authorities also definitely must work hand in hand in order to achieve this. And we have seen the example in the presentations that the national action plans on the country level, even on regional level, definitely will influence and make that happen. And as the extension of the AMR action plan in UK for extra 5 years, where part of their pillars is the prevention and preparedness. And the concept here reminds us that the antimicrobial resistance know no boundaries. Therefore, our defense also must equally interconnected as shared responsibilities that extends beyond the walls of our institutions would be really important to achieve this. So collaboration here is not something that it's optional as much as this is truly the foundation of sustainable impact. And we have seen also that in certain countries in our region where the policies for screening and prevention of healthcare associated infections started to make a good impact in fighting against antimicrobial resistance, and now leveraging that to the next level, how can the policies be implemented on the national level rather than only on the institutional level? There is another dimension also, which is always important, and that have been highlighted in the presentations of our estimable speakers, which is the financial dimension, that we must always communicate clearly to our decision makers that the cost of inaction in terms of prolonged length of stay, the treatment failures, and the lost productivity far exceeds the cost of implementing rapid diagnostics and preventing or preventive screening programs. Preventing an outbreak, this is something always when we talk about even sporadic cases where infections happen, cost far less than managing one of them. A single day or delayed identification of MDRO source or extended hospitalization cost more than the investment in a fast, accurate, and on-demand diagnostics that enable preventive measures. And the integration, that's very important because by integrating clinical, operational, and financial perspectives, we can definitely convince our leadership that diagnostic stewardship beside the infection control and prevention and the antimicrobial stewardship program is not just the moral duty as much as this is really a strategic advantage. So when hospitals invest in early detection, in prevention, they are not actually spending as much as that they are saving. And they are saving beds, saving antibiotics, and definitely saving lives. So stewardship programs are not just like, which is perceived to be like a financial burden. It's really a strategic investment in healthcare sustainability. And we conclude always when we talk about the awareness, and when it comes to the awareness week for antimicrobial resistance, let's carry forward the shared conviction that the fight against antimicrobial resistance begins long before the infection happens. It begins always with vigilance, with prevention, as with partnership, getting the stewardship committee and the hospital leaders taking the message that we came up with in the past few hours, that the earlier detection of the MDROs, data-driven actions, collaboration across all levels, and the prevention of the infection and taking these measures is the best defense against antimicrobial resistance. Thank you so much. And again, it's a privilege to be part of your estimable event today. I've learned a lot, and hopefully everybody do the same. Thank you so much.
Thank you so much, Mr. Ahmed, for that very, very important and critical thoughts which you shared with us. We're very appreciative of the hard work which you are doing, and thank you for your enlightening talk. And thank you for making it crisp, because we were very tired and it hit right where it should. And thank you so much. Professor Raman Sardana, closing words from you. Thank you, Dr. Zaima, for that lovely, lovely wrap up. And I'm happy to see that Professor Angarad is still with us. So Dr. Raman Sardana, please, the floor is yours.
Dr. Mayer, what to say about this? I mean, the symposium. it's been so well organized, and the speakers, oh my God, I mean they were par excellence, each one of them delivering what was expected and much more than that. So and the audience, the interaction and the questions that have been asking prove that they are great listeners, in fact, in this audience, and the people who have been interpreting also alongside. Um, the comments have been very encouraging, must say that, and grateful that we collaborated on this once again, Dr. Mayer, with Dash and with Sultan Caboose and ASM. So it's a great thing that we come together every year, and that you put in so much of labor into it, so much of brains into it, and a lot of coordination which happens. I mean, amazing. So much of time that you put in, and the colleagues at Dash, uh, amazing people, I must say. So grateful. HISI, from HISI side, we are really full of gratitude, and we are grateful that we collaborate together to bring out such a feast. In fact, thank you so much, everyone, Dr. Meher in particular, and your colleagues at Dash. Lovely.
Thank you, Dr. Zaima, and I are very thankful to everyone. We always wonder with this great panel of speakers and moderators, will we get the right audience? And that's always a concern, and really hats off to the audience. We could reach out through HISI, through the LinkedIn, through our platforms, the Dash PIs. We've had a fantastic evening today. Thank you so much, everyone. And looking forward to next year, another great session. Thank you. Thank you so much.
Have a great weekend. Lovely. And rest yourselves.
Working for us. It's working for us here. Dr. Zaima and I work on
Start working tomorrow.
Take a day or two off later on. Thank
She's
you.
a hard task master. She's making us, there's plenty of stuff to be done tomorrow and day after. So thank you, Dr. Zaima, also for
Lovely. Thank you so much.
Thank you, everyone. Thank you.
Thank you.
Thank you, Dr. Ashima and Dr. Shoaib and Dr. Rajni and Dr. Maria for that excellent.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Pragya. And all of you did a great job, by the way. All our resource persons did a great job. You added so much, what should I
We are
say?
blessed to be
Good.
part of this. We are blessed to be part of this. Right.
Thank you so much. Thank you so much. And we need to grow from here. We need to collaborate more and grow with our lovely friends.
Thanks to meetings and more also. Good colleagues
Yes,
and good
absolutely.
yeah.
They did a great job.
Very well
They did-
coordinated. Thank you.
Thank you so much.
Ma'am,
Thank you so much.
ma'am, I would like to play the video if you can. Someone is sharing the
yes.
screen.
Yeah, Mr. Ahmad, will you please stop sharing? There is one video which needs to be played. Dr. Sanjeev Singh had requested. They have this wonderful international.
Yes, it's done. I stopped sharing. You can start immediately. I'm sorry for that. I didn't realize that I'm keep sharing. Sorry.
No, that's okay. Thank you, Shalu, for remembering that. So that's where, meetings and more is doing such a wonderful job. And this is a great conference. I recommend everyone to go. I hope I can go. Dr. Zaima, it'll be great if you can also come. Let's see. But
No.
it's a message from Dr. Sanjeev Singh.
Oh, that's
They're holding this. They're holding this.
Hello everyone, I'm Dr. Sanjeev Singh. I'm a medical director at Amrita Hospital, Faridabad. I'm here to invite you for our international event.
We cannot see it,
November
Shalu.
Sorry,
this
we
year.
cannot see the video.
We've all
Yes.
seen the devastating impact of
Can't see
COVID-19
it.
pandemic, and there's a
When we're
group
not
which
able to see
emphasizes antimicrobial resistance,
No, we are
alarming
seeing your
rise in
files.
community
We are seeing
mortality.
your files.
चालू आप पहले
We all
स्टॉप
know
करो
the root
अपना
cause
वीडियो को
is
स्टॉप करो
irrational, unwarranted prescription, lack of
आप कर रहे हो शेयर?
रुको एक बारी मेरे को डाउनलोड करना था पहले
नहीं रहने दो. I'll just try it again.
everyone. I'm Dr. Sanjeev Singh. I'm a medical director at Amrita. Hello everyone, I'm Dr. Sanjeev Singh. I'm a medical director
Ma'am,
at
now it's visible?
Faridabad.
No.
Here
No, not yet.
national event in November this year. We've all seen the devastating impact of COVID-19 pandemic, and there is a glooming health crisis, antimicrobial resistance, with an alarming
I
rise of.
think the video is on VLC. Maybe that is why it is not playing.
So
You
let's
have
listen to
open
him
on
at least.
VLC.
Anji?
Oh, I
Let
think
us
the
listen
video
to
is
him.
on VLC mode. I think you have to open with VLC. Maybe that then it will play.
Hello, everyone. I'm Dr. Sanjeev Singh. I'm medical director at.
I think it's okay. We will share this video in
मैं
our
शेयर कर
group.
दूं?
हाँ,
हाँ,
share
कर
कर
दो।
दें. Yeah, right.
Yeah, we can see it now.
चालू मैं शेयर कर दूं वीडियो?
नहीं हो गया जस्ट a second.
Amrita Hospital, Faridabad. I'm here to invite you for our international event in November this year. We've all seen the devastating impact of COVID-19 pandemic, and there is a glooming health crisis, antimicrobial resistance, with an alarming rise of morbidity, mortality, and cost of care. We all know the root cause. It is irrational, unwarranted prescription, lack of evidence-based practices, looking at One Health, lack of standardization of laboratory, over-the-counter, unrestricted sales of antibiotics, so on and so forth. To address this urgent challenge, we are bringing together international and national talent for a two-day event on 29th and 30th of November this year. This event will have wide range of themes being discussed: advanced technology, point-of-care testing, AI, ML in AMR, virtual reality and extended reality in education, looking at cultural, contextual, behavioral therapies, we're looking at community-level practices and therapies, best practices in antimicrobial, antifungal, antitubercular, funding opportunities for research and innovation, looking at novel drug, which is there in the pipeline, and plenary sessions for national and global strategies and One Health and some of the applications for Trinity Challenge. We are also providing an opportunity for abstract and poster presentation. So this is a great learning opportunity, putting together a collaborative, multidisciplinary team, and we would really like to invite all of you to attend this particular program. Mark your calendar, 29th and 30th of November, scan the QR code and register as soon as possible.
So thank you. Thank you so much, Shalu. And I think now it's time to, again, as I was saying, thank you once again. Thank you, everyone. Time to disperse, I think. And Mr. Nitish Doshi also, very thankful for your constant support and guidance.
Thank you, ma'am.
And
Thank you so
excellence.
much.
Not at all.
Thank you.
So thank you.
Thank you.
Good night.
Namaste.
Good night,
Good night.
everyone. And
Good night.
we're so proud of everyone, and let's get down to doing better work together. Bye-bye. See you.
Bye.
Thank you.
Bye.
Bye. Welcome. Bye, Dr. Shoaib, Dr. Ashima, Dr. Sir, everyone. Bye.